Thanks for joining us today on this session. Special thanks to okay. Special thanks to organizers for giving us this opportunity and also this topic, which is not only a versatile one, very relevant to the present day situation, and also to all of us as practicing pediatricians. As the need for internet grows, so also the number of users keep increasing, and not only for adults, even from early childhood, we see that internet has become ubiquitous. It's part of our daily life, even starting from birth onwards. So as we were talking before, many of the school teachers, the school correspondents keep telling us that even as young mothers, as young as babies, from 6 months, 1 year onwards, we see them, they start moving their fingers on the screen of the phone. So that is one of the important milestones these babies achieve even before they achieve other milestones. So that is the amount of the impact of internet in the present day scenario. So today our topic is gaming, scrolling and streaming, how to understand this topic of problematic internet use in adolescence where it has its maximum impact. So let me welcome our three panelists. Dr. Usha Ilango. Ma'am is a senior pediatrician from Coimbatore and a forerunner in adolescent medicine here, and she is also a school correspondent, Perks Public School. Welcome, ma'am. Dr. Sri Priya. She is from Vellore and she is an adolescent pediatrician. For the past 10 to 12 years, she is doing great work in Vellore. Welcome. And Dr. Sharanya, our young, vibrant star from Salem. She has a teaching experience of 12 years at Vinayaka Medical Mission, who is also very much interested in adolescent pediatrics. Slides. Yeah. So now when we always start a topic, we need to know what is the impact of this issue. So we all know the number of adolescents is the highest in the world is in India. So we have 21 to 22% of our population being adolescents. So we are one of the young countries. At the same time, we also should understand that these people are going to be the future of our country. So if we take care of their physical and mental health, it is going to help our economy as well. And as you see here, we are the second largest user of internet in the world next to China. And the penetrance of the internet into villages is close to 65 to 70% now. That means internet is basically available everywhere. And we have moved from 3G, 4G, 5G and so on. So the speed with which we are able to use internet is also increasing. So it becomes more user-friendly and increases the number of users day by day. Not only is the screen time important, but it is also the content what we watch. So if we go through a study which elaborated on what is the screen time which our adolescents use on a daily basis through parental interview, it shows that almost 60% of them use internet more than 3 hours a day, of which around 34% use more than 6 hours, and only about 40% are using it within the norm what IAP specifies. And then there is a meta-analysis which was done by Joseph et al., which shows that in 2022, the prevalence of PIU was around 21 to 22%. That is just when the COVID had ended. And now this is a study which was done in Coimbatore by Dr. Lakshmi and myself. We were the key investigators, and we found out that the incidence in Coimbatore is close to 25%, and it was published in Indian Pediatrics. To just go through a few histories, why this internet addiction history started, it dates back to 1995 when Dr. Ivan Goldberg coined this term. And then Dr. Kimberly Young, a young psychologist, she framed the YIAT test to diagnose internet addiction. And then it was later modified by Bird and Wolf. And then DSM recognized this internet gaming disorder in 2013. And finally, WHO also included this gaming disorder in ICD-11. Of course, in a section where it mentions that further research is necessary. What are the factors which makes a child prone for internet addiction? It is biopsychosocial. In adolescence, we always approach a problem as biopsychosocial. So we have genetic causes like any other addiction. And we have also the comorbid conditions which can be present in the child like ADHD, autism, or obsessive compulsive disorder, or oppositional defiant disorders, and so on. And the environmental factors, that it is easily available, accessible, and it gives you company. And also, especially when a child has a low self-esteem, this helps the child cope up with the daily stress. So with this background, now I move to our panelists. So Dr. Usha ma'am, can you tell us what is problematic internet use to this audience, and why we are talking about adolescents? Why are they prone for this issue?
A very good afternoon to all of you. As you rightly pointed out, the percentages of internet usage, problematic internet usage, internet addiction is on the rise, not only among adolescents, but also in the smaller age groups. Now, the definition as it is, still we don't have a proper definition. It comes under impulsive disorders and is more rightly now moving into, it was more into counseling and psychology, it's moving into psychiatric disorders right now. A lot of papers published come in the psychiatric journals. So that much of impact it has done in the society. Excessive or uncontrolled internet usage that disrupts the child's day-to-day activity and disturbs their normal action is the current explanation or the current definition. Newer terms like nomophobia, cybergondria, so many cyber addiction, all these terminologies have come into focus based on this problematic internet addiction. Signs and symptoms, as you see, mood swings, irritability, sleep disturbances, academic fallouts, social emotional disturbances, and not having a good social interactions with their own family members and not only their peer group, and generally the overall health of the child becomes greatly affected. Now, why does this happen? Basically, the brain activity, which is still growing in children and also has a great plasticity. The midbrain is the most affected in this, especially the ventral tegmental areas, anterior frontal cortex, the cingula, insula, all these areas get affected because these ventral tegmental area especially is the dopaminergic receptor area. So once that is activated through internet viewing, there's a lot of push, or there is projected through efferent nerves to the other areas of the midbrain and gets the reward system activated, especially if it is the posterior frontal cortex or the nucleus accumbens. Once that happens, these are all the changes that is happening in the brain, and slowly in the very nascent phase or in the embryonic phase of internet addiction, the frontal cortex is affected and slowly the other midbrain areas get affected, resulting in gray matter reduction, and also the insula, which is more for the emotional, cortical thinning. So all these changes happens slowly over a period of time. And then the dopaminergic surge also happens. This gives them a sense of reward, a sense of satisfaction, which further mitigates towards more and more usage of internet. Towards the last phase of it, even the hippocampus, amygdaloid, all gets involved, and the dopaminergic receptors has such a surge. There is a disturbance in the reward system, the execution system, as well as the decision making. All these three get affected, and when the insula comes the emotional distress of these children, leading to depression, suicidal tendencies, and also this social behavioral attitudes. All this happens. So this midbrain activity is the most important area that gets compromised because of disturbance in this reward cycle.
Thank you, ma'am. I think that was a good explanation. If many people have been wondering what is this ABCD, it is Adolescent Brain Cognition Development Study, which is done in US. It's going on. About 18,000 children have been followed up from 8 to 10 years onwards, pre-teen till now. MRI has been done serially once in 6 months, and also they go through blood tests, and their behavior analysis, interview through parents, and they are finding out what changes have happened in the cognitive brain of these adolescents when they are exposed to internet. So the results are still not out, so this is a very big study. Now moving on to Dr. Sharanya, can you explain the different terms which are associated with PAU? Because we hear internet gaming disorder, and then there are so many colloquial terms used by our Gen Z kids which we are not aware. But as pediatricians, when we interview them, I think we should be aware of that.
Yes, ma'am. Good afternoon, one and all. So the various terminologies related to problematic internet use are, first one is internet addiction disorder. It's nothing but using excessive internet, which negatively affects the mental well-being as well as the work performance and mental well-being also. While IGD, internet gaming disorder, is recognized by WHO and included in ICD-11. It is characterized by severely reduced control over gaming habits. What happens, it replaces, gaming becomes a problem when it starts replacing the sleep, responsibilities, and also their duties. So when relationships also. So IGD become a disorder. It is recognized by WHO and ICD-11 and also included in DSM-5. Next is doom scrolling. That is what everyone does, right? As soon as we get up in the morning, we open our WhatsApp or YouTube and start scrolling. So doom scrolling is persistently consuming more of negative news and distressing information. That is what the algorithmic pull of an internet is. What it does is it feed us with negative news. So once in a while, if we get a positive news, we get a reward. So we keep on scrolling more and more of negative news. That is doom scrolling. Next is zombie scrolling syndrome, which is nothing but we keep on scrolling without any endpoint, because our internet will load us with more and more content, more and more reels and shorts, so we will keep on moving. That is zombie scrolling. Streaming disorder, everyone, yes, does, right? We keep on watching all the episodes. We go season by season in online content. That is streaming disorder. Problematic social media usage is uncontrolled involvement in all the social media platforms. Not to forget is cyberbullying, where harassing another individual in electronic form is cyberbullying.
Yeah. Now with this background understanding, let us move to 2 or 3 children who presented to us. So here we have a 15-year-old girl. She presented with excessive fatigue, poor concentration, and headache. And this was going on for a period of over 3 months with irritability and social withdrawal. Dr. Sharanya, how do you approach this child?
Yes, ma'am. This child, on probing, she revealed she developed the habit of using mobile in the late nights and also till early morning because of unsupervised parental control, and also she had recent stress, academic stress. To escape from that, she started scrolling. So it became a habit for her, and she mostly consumed negative news, disasters like plane crash news, Kolkata disaster. So whatever she gets negative news, she started consuming more of disasters, crime reports, and controversies, divorce cases. So she described a compulsive urge to stay updated and for fear of missing out, FOMO, but still she's not able to stop this behavior. On Head's assessment, the main positive points are she lives with working parents, her screen usage is unsupervised, and there is recent decline in her grades, and there is inactivity. She has stopped all her physical activity, no exercise, no play, and she has also quit her music class, and she started scrolling mobile. That is the main activity she does. And there is a very poor sleep hygiene. She doesn't sleep well in the night. After she gets up also, she feels tired, and there is daytime fatigability is there. And on focused physical examination, the main points are anemia is present, dark circles under the eyes, always anxious affect. She is nervous, restless, and also tired appearance. Her attention span is also reduced. And what happened was, with this, we planned for the next is screening. So we applied the tool, the most widely used and validated tool, PRIAS, Problematic and Risky Internet Use Screening Scale. It has got 18 items under 3 subscales, social impairment and impulsive behavior and also emotional impairment. Her score was around 52. When the score is more than or equal to 25, we can take it as positive and we can diagnose as problematic internet usage. And subtype is doom scrolling. With the PHQ-9 questionnaire, she was also found to have moderate depressive symptoms.
So how did you manage this child?
This child required a psychoeducation. Psychoeducation is not only the sharing the information or sharing about the nature of illness, we also teach the child about self-management and also for developing coping skills. And she was also educated about digital hygiene counseling and strict sleep hygiene measures, and also family. The whole family has to be involved. They're taught about digital hygiene.
Thank you. So she highlighted very well the importance of not only talking to the child and helping the child, the family has to be involved, and multi-prong approach is needed, and we should always partner with a psychologist and psychiatrist on board whenever necessary. Thanks for highlighting that. Moving to Dr. Shripriya. So we know that problematic internet use need not present alone. Most of the times it is a bundle. It can be a manifestation of a comorbid condition present from early childhood, or it may lead to comorbid conditions like depression or anxiety. So can you elaborate on how PAU presents in these people?
Yes, there is a high prevalence of underlying psychopathological conditions as well as comorbid disorders in problematic internet use. But the transactional relationship between these is very complex. Just to simplify it for our understanding, in the internalizing disorders like depression and social anxiety, they use internet for coping up as escapism or to compensate for the absence of interpersonal communication. Whereas in externalizing disorders like ADHD, obsessive compulsive disorder, oppositional defiant disorder, substance use, conduct disorders, in all this, the impulse control is very poor. The decision making is also very poor. They easily are attracted towards immediate rewards, and there is an increased desire for novelty seeking, and the stress tolerance is also the threshold is also very low. So because of all these things, they are more going towards problematic internet use. Always, not all the clinical features will be present. Sometimes there will be only subtle deficits and differences, but you have to identify these and attend these for proper intervention of the child.
Can we discuss the history of a 14-year-old boy who presented with excessive gaming?
Yeah, Nibav came to us due to spending excess time on the online games. He was spending more than 3 hours per day. Whenever his gaming partners were online, he was obligated to be online. His parents reported frequent arguments and he refused to attend any family activities. He was diagnosed previously with ADHD at 10 years of age, but he stopped medications, attention problems, impulsivity persisting since then. Next. On Head's assessment, he was a single child with IT professional parents. Father had a history of ADHD in his childhood, and the parenting method was very lax, and the parental presence was inconsistent. There was also increased digital media use by the parent. His academic performance was falling, and he plays for more than 3 hours up to 1 a.m. in the night, massive multimedia online role-playing games, and poor sleep hygiene. Next. As Madam said, the biopsychosocial model is followed for problematic internet use also. That is the basic pathology. So all the 3 domains, biological, psychological, social domains, the factors are identified. Predisposing factors, precipitating factors, perpetuating factors, and protective factors which can be used as strengths in intervention are also identified. On examination, he was very restless and easily distractible. Next. ADHD rating scale, his total percentile score was 98, and psychologist assessment was got for internet gaming. Next. Diagnosis was attention deficit hyperactive disorder, combined type, comorbidity, internet gaming disorder with insomnia. Next. And he was managed with psychoeducation. Methylphenidate was started for ADHD, and psychosocial intervention also done. Cognitive behavior therapy and family therapy was also added. Everything will be briefed later.
Thank you so much for highlighting the importance of always screen for any other comorbid condition whenever a child comes with a problematic internet use. Ma'am, can you quickly guide us through the anticipatory guidelines, what you would like to give a teacher, pediatricians here, as well as the child?
I think already as mentioned, to recognize this as early as possible, having a family study, heads assessment and all that, so recognize it as early as possible. And also the CBT, cognitive behavioral strategies. That is really helpful in the initial stages so that those children can go through that. And non-digital rewards, positive reinforcement, which means to recalibrate. As you saw earlier, the brain has been tuned to internet addiction, and the reward system was working with the dopaminergic surge. Now we have to recalibrate that reward system through positive reinforcement, which could be some other reward system. But that doesn't come that easily because the natural reward system works very slowly for children who are exposed. Very early, it recalibrates much quickly, but in the later stage, it's quite difficult, but still we can persist in using these non-digital rewards, especially when they are involved in many other activities, which we are going to later talk upon. Is the huge change is the exercise change that is happening in these children. And also to have a very secure and social relationships. For teachers, usually we tell them that to give them a secure classroom environment as well as good friends, because sometimes they become so isolated that the isolation becomes so severe they go into depression. So we do make teachers aware of their problems and counsel the parents and counsel the teachers and give them a very secure peer group relationship. That is actually very important, that has helped in a lot of times. And of course, not to improve the sleep, to improve their behavioral modification, exercise is playing a huge role in bringing this modification and also to bring their emotional change. So exercise intervention, aerobics. Later we are going to show one study which was done in China for about 1,500 students, especially children who had this gaming addiction in the moderate and very severe stage. So this study was done for about exercise in 6 weeks, 6 months and 9 months duration to see the changes, and tremendous neurogenesis was seen through aerobic exercises, and also teaming in sports, both mind-body correlating sports as well as some kind of mind games like chess. And so these were very, very important, and the study has proved that they were able to recover or recalibrate or get these children totally out of the internet addiction. So guidelines, clear screen time. Time and again, IAP, AAP, all of us have been talking about screen time limits, but we are at crossroads. As an educationist and as a pediatrician, I am sometimes confused about this smart classrooms. On one side, parents really want smart classrooms. They want tablets to be given in the class, a lot of classwork to be done, a lot of assignments to be submitted, but I am actually against it. So that way, in schools, we can limit the screen time by having a hybrid type of education and have a clear screen time limit according to the age group as prescribed by IAP. And the monitoring tools, these are very important and very useful. You can give it to the parents, this Apple screen time and the Android digital well-being. These are so good that you can download those and they actually give you warning signals and when you exceed that time to the parents as well as to the child. And also have that availability of mobiles or tabs or according to the age group. Somebody who is in a lower class does not need a tab all the time. So that is also important. These two tools I checked it myself and I use it for our parents too, and it is quite good. And also the quality time of parents spent, more educative, more skill building, and passive consumption. For example, even parents who are watching late night TVs or mobiles, children do sit with them. And during eating, so a lot of their activities is combined with internet viewing. Very, very important is family time, family things to do together, exercise, exercise, exercise. It is time and again, it has been proven that not only for internet viewing, but otherwise also for a general health of these children, exercises, sports should be made compulsory and should be given to all these children from a very young age. This dopaminergic surge can be shown not due to internet addiction, but due to your exercise, due to your good hormones that secretes due to after a good workout. That kind of an experience should be given to these children. In schools, I would advise hybrid education, which means it should be a mix of traditional education. I'm not saying Gurukul, but the traditional way of teaching from the board rather than smart class. Yes, we do have smart class, but limited to the subject that is required probably for an hour or two, the previous one, the hour or two, and also have the traditional teaching and limit the screen time to their education and skill building activities. Compulsory sports and exercise is very, 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 very important, and that actually adds, it's a holistic thing that is happening to the child. Smart boards to be in schools to be used judiciously, and also schools to be advised, and guidelines should be given to every school. Every pediatrician should try to connect with the schools locally and give them guidelines. Most of them actually are clueless about it. So give them guidelines exactly how to go about this and how to guide them to reach the pediatrician or the caregiver at the very early stage of internet addiction.
Thank you for highlighting, ma'am. I think that was a big take-home message that as pediatricians, we have to give that anticipatory guidance, anticipate this problem early, not just in adolescence, even before that, and approach schools where you can do it as part of our social responsibility to help these children not get into this problem. And two things, as ma'am said, one is sports, sports, sports. We should not stop them from their hobbies and sports once they reach 9th grade. And second is parenting. Parenting has to be a role model before they insist on the child's screen time to be limited. Now moving to Dr.
Jayashree, I would like to add one more point. National Education Policy of 2024, the CBSE, also has given definitive guidelines of usage of the smart boards and panels in schools. But at the same time, more and more parents are requesting to have smart boards and smart panels and tabs to be given. So a combined representation from the school sides, the management associations have represented the CBSE board, the NEP for the National Education Policy, to give definitive guidelines to schools accordingly to limit the screen time for skill building as well as for educational purposes. So this I am stressing, pediatricians as well as national representations from pediatric association also should be made to the central NEP board, CBSE board, other matriculation board, so that a common norm is formed for the screen time in schools.
Dr. Sripriya, can you briefly outline the interventional strategies? We have moved from guidance to what intervention you can do.
Yeah. There are two types of prevention. One is the indicated prevention in the adolescents who have already developed the problem, and the other is for the adolescents who are at risk. So for the adolescents who have already developed the problem, psychoeducation is the first line of treatment. Explain both the parent and the adolescents about the issue and the need for long-term therapy. Reframe the problem, that is, have an alternate explanatory model. Tell them that the problematic internet use is an epiphenomenon of so many underlying problems which has been there for quite a long time, like academic difficulties, easy distractibility, etc. And then they'll come to a realization, oh, is it because of that this is all happening? Oh, then if that is attended, will this be improved? Then they'll be ready for treatment. Motivational interviewing can be used to motivate for change. Cognitive behavior therapy is the cornerstone for treatment. It is usually done over a period of 12 weeks by a psychologist. First phase is behavior modification phase, where we can ask them to modify the behaviors by using daily internet log, using external stoppers, timers, reminder cues, setting goals, or entering a social support group. And the next phase is correcting the distorted thoughts, like they might be thinking that this is the only resort for them for peace. All these things has to be corrected. And the third phase is harm reduction. Next. Dialectal behavior therapy is one form of cognitive behavior therapy which can be used especially if there is emotional dysregulation. Treat the co-occurring problems, structure the day. Daily scheduled activities will help the child, will give a form to the child's day. And and brief strategic family therapy is very much important if there are dysfunctional family patterns. Restructure only if these patterns are directly related to the problem, like parenting style, poor communication, poor conflict resolution, many patterns which have been passed on through generations. All these things, if they are directly causing the problem, then restructure it, help them to restructure it. Selective prevention for adolescents at risk, screening and follow-up.
Thank you. And now moving on to Dr. Sripriya, can you highlight the screen time recommendations by IAP for the audience?
Yeah, for adolescents, they have to balance the screen time. So they have to give time 1 hour for outdoor physical activity, 8 to 9 hours sleep, time for schoolwork, meals, hobbies, peer interaction, family time, and the parents should educate the child about safe and healthy use, monitor their use, give media literacy, and they should be updated and they should be role models.
Thank you so much. Can you name some apps, Dr. Sharanya, which will help in, so we all know this proverb, mulla mullala da edukano. So same way, can we use some digital apps to help us to maintain our digital hygiene?
Definitely, ma'am. As you said, famous Vadachinai dialogue, why don't we use same digital media to control our digital addiction? There are so many apps, parental control apps like Custodio, Ion Kit, which helps to block the problematic apps and also to remove the unwanted websites. And you can also tag local location control. So you can monitor your kid very well.
Have you used anything personally
in this? My personal favorite is a Stay Free app, which is very good in blocking particular sections of an app. We can just block the shorts alone. You can watch long videos in YouTube, but still you can block the shorts. You can take up WhatsApp messages, but you can block the WhatsApp status. So it's very helpful. Similarly, we can use Forest app, Rescue Time, Be Focused, which all helps in more focused work of us. And moving to about this first of its kind in our country, Shut Clinic, service for healthy use of technology and digital de-addiction. It is working in NIMANS, not in the main campus, another campus of NIMANS Center for Well-Being. They are providing one-on-one counseling for people who are severely digitally addicted, like watching a lot of porns and going on online trading like online rummy, and also in severe internet gaming disorders. So for these people, they are providing de-addiction control therapy, and also they provide tele-helpline. So this is totally free. We can call in particular timings and particular days where they will provide counseling for us. And they also do weekend service for support programs for parents. And they also have advised for digital fasting. Once in a week, the whole family can go for no phone Sunday, tech-free Tuesday. The whole family can keep the mobile devices and screen away, and they can spend quality time in the family.
Thank you. So we had many opening clinics. Now we have shut clinics, which is very important to also stop the adolescents from entering into problematic internet use, and also have rehabilitation centers like alcohol de-addiction. Now we have rehab centers in our country where we have to help these children come out of this. Sometimes it goes to the extent of using medications. Many psychiatrists now use naltrexone like drugs for internet addiction too. So coming to the end of the session, quickly all three panelists, can you give your key takeaways for the audience? And we will have 1 or 2 minutes for audience interaction. Ma'am?
We all know internet is here to stay. It's not going to go away. Except for some countries, I think you removed that slide. Anyway, I'm going to say that. Some of the countries, European countries, Australia, Finland, Germany, a lot of countries have taken away mobiles from the children and have banned it, completely banned it. They have banned it because they are not able to manage this surge and this amount of adolescents' internet addiction, and they have simply banned it. So are we going to go towards that, or are we going to educate our society, especially parents, and work together with the schools and teachers and bring awareness, a lot of awareness? Commonly, we see a lot of even small children being subjected to screens just for, even feeding them. So this has to stop to safeguard our children. And we should work together with schools, pediatricians. I really, really request that you should be well connected to the schools nearby and give them exact guidelines, and this will really work well. And definite family times, digital break, digital, weekend break, digital being away from it, digital fasting, you can name it, but we need that time off from the screens, especially during the weekends. As maybe they can work with their screens during the week, but the weekends they should be off screen. So that kind of a balance has to be taught to parents and to the children, especially adolescents, and guide them effectively and give them also Actually, there was a Tableau column which says like how we do in our school is Monday to break from their activity, we give them every day a different activity to upskill themselves and to learn a new skill, and also give the screen time to 2 hours in a day, of which 1 hour to 1 hour, 15 minutes will be for their lessons, and then the 45 minutes is to their liking. So this way it has worked out wonderfully well, and a lot of actually adolescents cooperated very well. And exercise. We make it very compulsory in our schools that we make sure that they have their 45 minutes of their PT and engage them in more competitive sports. And I don't find that many of them, but I do counsel a lot of children to go into sport and also encourage parents. This has shown, sport exercise has shown very good neurogenesis, and also the plasticity, or the synaptic and the dendritic plasticity, all returning to normal and, you know, calibrating to normal levels. It has shown, many studies have been shown that exercise is the bottom line, because pharmacotherapy, side effects. CBTs, yes, but it is child dependent, parent dependent.
And expensive also.
And expensive to each time to go for therapies. So this is so simple. It's not like buying new shoes and going to a gym. It's just exposing the child to natural dopaminergic surge.
Thank you, ma'am. And now to Shri Priya, Sharanya.
Ma'am, my take-home message is the role of pediatricians to find out this PIU in adolescence. First, we have maintain high index of suspicion. Whenever there is an academic decline, or whenever there is poor sleep hygiene, mood swings, we are supposed to suspect PIU, and we have to normalize the conversation. How we normalize the consumption of junk food, their family time. Similarly, we have to ask for the online timing also, and we have to provide anticipatory guidance to the parents regarding their screen limits, how the duration of time their children should be exposed to the screen. And whenever we have a doubt, always apply the screening tool priors and detect it early. And the final thing is, we have to always follow up, because if you don't follow up, there are high chances of relapse. So we have to do a follow up every time.
Dr. Shri Priya.
This is in continuation with Usha ma'am's stress on physical play. As we call upon the teenagers to limit the internet use, we as a society should carry a collective responsibility to create rich opportunities and safe spaces for children, for our adolescents, for their physical play and creative exploration. And are we doing that? Let us all think.
Thank you so much. And I end with this slide, which was really surprising to us. This is the building of Coimbatore Medical College Hospital, and this news came up recently in Dinamalar. There is a center called Kalangarai, which is the government's initiative that every medical college hospital should have a internet de-addiction center. And in our Coimbatore Medical College Hospital, we have 25 to 30 children reaching out every month. And there are also inpatients who are treated with pediatricians with the help of psychiatrists and psychologists. So this is to the extent that this problem has come up, and most of the inpatients are adolescents. So let us think and act, and also follow whatever our panelists say, that the least we can do is to sensitize the parents and also our children and prevent them from entering into problematic internet use. Thank you so much for patient listening. Thank you, all the three panelists. You made such a wonderful points and brought out the importance so well. Thank you so much.
Thank you, ma'am. It was a very wonderful session, and was very eye-opening. Now I Dr. Shanmuganathan next session. Sir is a senior consultant pediatrician. Pondicherry. For year 2021, sir has received Balgopal Raju Active Pediatrician Award for the year 2023, and he is an IAP most IAP positive member for 2024, and currently he is IAP Knowledge Safety Member.
Imminent events supposed to be taken the things after every post-lunch session. This session is supposed to be eye opener for all. This is because due to the ticking time bomb of the severe LV dysfunction of these things. Our Dr. Devaprasad sir is a senior consultant cardiologist in working as a Ramakrishna Hospital. His delivery is his speech. Over to you, sir.
Good afternoon, everyone. First of all, I take this opportunity to thank KONGU PEDICON 2020 and all the delegates present here for giving me this opportunity to speak in front of the body. So let's straight away go to the topic. Post-lunch session, and everybody are socializing with all your friends. And now, after the quick lunch, everybody are speaking. So now let's go to the topic. So my topic is ticking time bomb. What is ticking time bomb is? You made the diagnosis and the child is going to die at any time. So it's like the time bomb started ticking and you need to make a quick decision to defuse the bomb, or you need to make a quick diagnosis to find out the treatable cause. Not only a treatable cause, it has to be cured and the child has to be get rid of the disease. So most of the time it is heart failure. So what is the definition of heart failure? So it's heart failure in children is a clinical and pathophysiological syndrome which results from ventricular dysfunction, or it may be because of volume or pressure overload, or it can be either both ventricular dysfunction as well as volume and pressure overload. It has characteristic signs and symptoms such as poor growth, feeding difficulty, respiratory distress, exercise intolerance, and fatigue. And it is often associated with circulatory, neurohumoral, and molecular abnormalities. So these are the definitions we studied in the PG times, but practically when you see the child is very sick, with circulatory failure, and you get the echo done, it is showing severe LV dysfunction. So who all will have LV dysfunction? So in heart failure, 30% heart failure because of congenital heart disease, 30% heart failure because of cardiomyopathy, and 33% will be combined causes. So if we see congenital heart disease alone, the chance of developing ventricular dysfunction and heart failure which requiring advanced treatment is very less. But if you take cardiomyopathy, eventually 100% will have ventricular dysfunction, and eventually most of them, maximum 65%, will end up in heart failure which requires advanced treatment including transplant. So there are few lesions where if you make a correct diagnosis, you can diffuse the ticking time bomb and they can get away with the LV dysfunction, and the LV function will become normal, and it will be a good prognosis. So coming to the heart failure, there are two types of heart failure, where the heart failure where the LV function is preserved. For example, if you see these echo images, the heart is pumping very well, the squeezing very well, and cardiac output is maintained. The other subset of heart failure is LV function with reduced ejection fraction. Here you can see the LV is hardly contracted. And these people who are near the wire, they will say that we have...
We're out of time. We just have to hope he has it.
Okay, we're ready.
At 2 seconds.
The cliff, and the bomb is diffused. So the point of this video is, it is a bad disease, it is a ticking time bomb, but yes, 10 to 20% of the time you can identify some reversible causes and you can get away before the bomb blasts. So that is a dilated cardiomyopathy. These are the various causes. I think most of them will be knowing. So what common referral as a pediatric cardiologist we get is severe heart failure child, somewhere echo might be done, severe LV dysfunction, and some history of vague fever, and they will be referred as viral myocarditis. And also they might have received treatment outside for viral myocarditis. Usually this post-viral myocarditis, DCM, they will receive a cocktail of congestive cardiac failure medicines, Lasix, NVAC, digoxin. Only these 3 drugs we have. And invariably, everybody might have received IVIG and methylprednisolone. And this, everybody are aware, in COVID situation, we got the COVID MIS-C, where the Kawasaki-like disease presented with LV dysfunction rather than coronary abnormalities. So few cases which I got as referred as post-viral myocarditis, how did I diffuse this bomb? So this is what I'm going to share you in the next few minutes. The first case, this may be common causes to rare causes. Let us go to each case. First is a 10-day-old neonate, again presented with congestive cardiac failure and referred as dilated cardiomyopathy. Echo EF was 20%, intubated, ventilated, very sick child. With a straightforward diagnosis, this is the arch of aorta. You can see a very tight coac. So in this situation, with 10% EF, surgery is not possible. So the easier way is to cannulate the axillary artery, balloon dilate it, and the LV function become totally normal. A week later, child underwent coac repair, and till now the child is doing extremely well. The second scenario is again after neonate, is a 3-month-old child, again referred to as dilated cardiomyopathy. This is a scary looking heart. You can see the left ventricle hardly contracting. And this is the ECG. I will come back to the ECG later. The CT scan we did after having a lot of discussion showed this is the pulmonary artery, and from the pulmonary artery the left coronary artery is arising, and this is the right coronary artery which is arising from the aorta. So this is the pulmonary artery, the left coronary artery is arising from the pulmonary artery. This is also the very well known diagnosis. This is Al-Kappa. Usually they present at 6 to 8 weeks of age. They will have coronary steal, LV dysfunction, and they present extremely sick. So the take-home message here is ECG. So what is the clinching finding in ECG is Q waves in lead 1 and AVL. So most of the time in children, 2-3 AVF, you will have Q waves. Whenever you see Q waves in lead 1 and AVL, it is Al-Kappa unless proved otherwise. Even the echo report says that coronary is normal, it is Al-Kappa. Even the CT report says coronary is normal, it is Al-Kappa. So the take-home message for this case is the ECG. You can see the deep Q waves in 1 and very, very deep Q waves in the abnormal Q waves in the lead AVL. So again, this third case is a 3-month-old baby, came with again EF of 10%, congestive cardiac failure. Here the child had a high-grade fever for a few days, a week back. So again, this is a scary looking LV. Same 3 months old age, we will look for Al-Kappa. The same, there was no Al-Kappa and echo as well as on ECG. So in our unit, we had a discussion. We made a diagnosis of post-viral myocarditis. The child received anti-ECC of cocktail medicines, IVIG. To the surprise, the child, baby EF improved to 40%. But to the dismay, within a week later, the child again presented with severe LV dysfunction, very sick, EF of 15% with renal failure. So this is the echo again after 1 week. The left ventricle is hardly contracting.
So this is a general rule in undergraduate and postgraduate teaching, that any child who receives cardiac medicines, who develops renal failure, first drug of culprit is the NVAS. And if we give NVAS and the child develops renal failure, we need to look for a renal Doppler. So this child was provisionally diagnosed as renal artery stenosis, but surprisingly, we took the child for balloon dilatation. Here you can see the aorta is cut off. From the liver, the lower part of the aorta is totally not filled. Second angio, from down we give angio, so from there is a long segment coarctation for this baby. So with the help of vascular surgeon and CTVS standby, with the very high risk, very small baby, 3 months old, we balloon dilated it. So this is the balloon dilatation done, and post balloon dilatation, the aorta start filling, and this is the final result. So this particular child, within a week of ICU management, the EF became totally normal, and the child is now 4 years and going to school. With a lot of investigation and consultation with pediatric rheumatologist, this diagnosis turned out to be Takayasu arthritis, and child is in follow-up. The LV function is totally normal, but the Takayasu disease is treated by rheumatologists with mycophenolate mofetil and tocopherol. So coming to the next case, again we got a 6-year-old male child who was admitted, who was referred to our adult cardiology colleague, and after echo he called me and told there is a severe LV dysfunction, child is sick. So this is a history, usual history, dyspnea on exertion, fever, palpitation, vomiting, and you examine him, he has all signs of congestive cardiac failure. And this again his echo, it's a bigger child, you can see the little bigger heart, the LV is hardly contracting. So again we had a discussion, same diagnosis, myocarditis, and we treated with all ICU cocktail medicines and IVIG. Within few days his LV function marginally improved, and his hemodynamics was little better. Now here the clinical clue, simple clinical clue only was on examination we got, the upper limb and lower limb pressure pulse was a little different, and there was a pressure difference. So but echo was normal. In spite of searching in the usual coarctation area, there was no coarctation. So we did a CT aortogram. Here you can see the coarctation in a bigger child, 7-year-old child, in a different area. So here the coarctation is in the abdomen, mid thoracic aorta, and again the age of the child is 6 years, bigger child. So we balloon dilated it. Balloon dilated did work well, and here we had a dilemma with our radiologists and the team. It can be a congenital coarctation of aorta, or it can be a Takayasu arthritis. So we had a team of doctors discuss, and we finally told that it is only a coarctation of aorta in an unusual place. So we balloon dilated. This is the final angiogram, better than before. So 6 months later, again he came with 10 to 20% EF. He was very sick this time. So this time again CT showing again narrowing. This time the diagnosis was very clear. There was wall thickening in the aorta, and it is nothing but Takayasu arthritis at 6 years of age child. Again, this is a scary looking LV, hardly contracting. This time we didn't take a chance in balloon dilatation. We deployed a stent. Here you can see the stent is expanding, and this is the final angiogram. You can see the stent is in well place, and this LV, within 2 days his LV functions became normal. This is his discharge echo. Beautifully the LV is contracting very well, and he is hemodynamically stable. Past 4 years he is coming to follow up with us, and he is totally asymptomatic. So move on to the next case. Then again little bigger child, 10-year-old child. Again he came with the scary looking X-ray, cardiomegaly, and similar symptoms of heart failure and signs of heart failure, very sick. So again this is the echo. The LV is very hardly contracting. So routine echo, normal, no congenital heart disease. EF was only 10 to 15%. Again, same cocktail of medicines, IVIG, anti-CCF medication. He never improved. He had a marginal improvement. And while in ECG we had a little clue. He had some few ectopics. So we thought we will do a Holter and see. To a surprise Holter, it came as out of 3.6 lakhs beats, 1.2 lakhs beats he had ventricular ectopics with a lot of runs of ventricular tachycardia. So this is the Holter picking up multiple runs of ventricular tachycardia. So this is nothing but tachycardia induced cardiomyopathy. So we have a treatment for this electrophysiological study and radio frequency ablation. Our electrophysiology team in our hospital ablated the pathway, and he is totally symptom free now, and his EF is 50%, and he is no more symptomatic, and his LV function improved. So these are there are many other causes as well. These are the few clinical situations we have met in our department. So when you don't have any treatable cause, definitely you cannot diffuse the wire. It's going to burst, and the mortality is very high. But one thing is genetic testing we can do. Why genetic testing? Because there is an entity called idiopathic cardiomyopathy. If you diagnose idiopathic cardiomyopathy also, it is relatively little better prognosis than the other cardiomyopathies, because if you see the survival rate, so who has more survival rate when you have cardiomyopathy? It is peripartum cardiomyopathy. So if you give some time and medicines, they have a chance of LV becoming normal. The second in line is the idiopathic cardiomyopathy, which is very common in children. So they will live little longer. You can experiment with multiple drugs. There are a lot of newer drugs available now for heart failure treatment in children, like sacubitril, valsartan, risoguat, and so many SGLT anti-diabetic drugs, dapagliflozin. These are many drugs available. So you have some time. When you take other causes of cardiomyopathy, dilated, restrictive, they don't give you time. Ultimately, even if you manage in very big centers, they ultimately end up in transplant. Waiting in transplant, they die. So next little less severe disease is idiopathic cardiomyopathy. So if you don't find any cause, then you term it as idiopathic cardiomyopathy. Familial, 30% of the familial cardiomyopathies are idiopathic. So you need to do a genetic test. So in our unit, what the common genetic mutation we get is TNNT2 mutations. So coming to cardiomyopathies, all cardiomyopathies are bad. One dilated cardiomyopathy, what are all the clinical diagnoses I told? If you are diagnosed at correct time, you can definitely diffuse the bomb. The other two patients we have is congenital acyl carnitine deficiency, which you can detect only by a genetic testing. So these children, when you give acyl carnitine syrup or carnitine supplementation, their LV will totally become normal. It is much better than us also. So other rare causes like hypertrophic restrictive cardiomyopathy, you cannot diffuse the bomb even if you are a Tom Cruise. So with this presentation, I think even though it is a very bad disease, there are few conditions which you correctly diagnose at correct time with the help of a big team. You can definitely diffuse the bomb. Even though you cannot diffuse a bomb like a Hollywood, you can diffuse the bomb like a Tollywood. Volume. This is NTR, for many of you don't know, his older picture. He diffuses the bomb in a Desi style. That's all, diffuse. So to conclude, yes, dilated cardiomyopathy is a very serious condition, but within the challenges, there is definitely hope. So you have to identify treatable causes and also curable causes, because it will guide to improve the outcomes and brighter tomorrow. So in this treatable causes, I want to emphasize again, yes, congenital heart disease are there. It is easy because you have adult cardiologists also, you can pick up a lot of congenital heart disease, and no need for an echo. With the clinical examination only, I think with the good clinical program our IAP and the medical colleges run, clinically only you can diagnose congenital heart disease. If you diagnose congenital heart disease, if you treat the congenital heart disease, 100% guarantee that the child will have a normal life. Yes, viral myocarditis, many of them encounter. We also have cases. My experience is viral myocarditis, they present at 10% LVD, 10 to 15% EF, 20% only AF becomes normal. Rest of the children will chronically have LV dysfunction. Some point of their life they will need transplant, but transplant is always out of bounds to poor people, and also because there is only one heart. So they eventually die. Next important cause is Takayasu arthritis. Takayasu arthritis, pulseless disease, which we have learned in the MBBS time, always in theory and imaginations. When you see in reality, they do exist. We have to have high suspicion, and they will have unusual site of obstruction. So traditional teaching in pediatric cardiology, Takayasu arteritis, they will have subclavian stenosis, and they will have multiple areas of stenosis. These children, what I have seen is only isolated single area of stenosis. Another thing, important thing is do a Holter in a child. So whenever they have a very low heart rate or very high heart rate, any suspicion is there, 3 to 4 days of Holter will definitely pick you up. Another important thing is genetic testing. So nowadays, I think many of them are now coming forward and doing genetic testing. Acylcarnitine, congenital acylcarnitine deficiency, I have 2 patients. The last one is the vitamin D metabolism deficiency. I have not seen one patient, but there are a lot of literature reports says that if there is alteration in vitamin D metabolism disorders, they will have LV dysfunction. And if you identify with a good endocrinologist, pediatric endocrinologist, the LV dysfunction, you can diffuse the bomb. So thank you everyone for the patient listening, and grateful for your attention. Thank you.
Thank you, sir. Thank you, sir. Excellent speak, sir. This is typical eye-opening. தூக்கத்திலிருந்து வீழ்ச்சிட்டாங்க. That is the criteria. It's a time taken. It's a time bomb, ticking time bomb. நம்ம பாம் அவர்கிட்ட விட்டுருவோம். டைம் மட்டும் நம்மகிட்ட வச்சுக்கோம். The time means triage quickly, ionotropes early, mechanical support before with crash, and expert referral immediately. TIME முடிஞ்சு போச்சு. அது மட்டும் ஜெனரல் ப்ராக்டிஸ் நம்ம வச்சுக்கிட்டா போதும். பேலன்ஸ்லாம் அவர் பார்த்துக்கிட்டோம். No problem. Thank you, sir. Our next speaker, don't know the introduction. It's one of the main pillar of our organization, or that is organizing committee, Madam Lakshanti ma'am. Over to you, ma'am, please, for learning disabilities.
Thank you, Sharmanathan sir. Good afternoon, one and all. So I should first thank my good friends in the scientific committee, Dr. Ashwath sir, Dr. Ahila, Dr. Jayavardhana, for giving me a topic out of the box, like away from what I practice or preach. Thanks to them that I got to learn something about this. I had to do a lot of firm work with good help from my good friends, Dr. Sutagar, Dr. Malligai. So I'll try to do justice to this topic. And that was an interesting presentation by Dr. Dev Prasad sir. So coming to the topic. So the topic given to me is a sort of a debate. So it says mainstream schools versus special schools for children with learning disabilities. It's a bit controversial topic. So I just saw it from a different perspective. So maybe a pediatrician, general pediatrician would view it from a different perspective. A developmental pediatrician would view it from a different perspective. So I present my perspective here. So coming to the scope of my talk, I'll just give a brief overview of what is learning disability and what is inclusive education, the behavior issues that we see in learning disability, which is often disregarded, and the interventions and the way forward. Okay, so coming to learning disability, it's a heterogeneous group of disorders with impairment in cognitive processing. And there are specific and persistent difficulties in reading, writing, and mathematical abilities, as we all know, and persistence of difficulties despite normal intelligence. So this is the main point here. So children with LD have a normal intelligence, and despite normal intelligence, absence of sensory impairments, conventional instructions, good motivation, and adequate opportunity. Every point here is very important. Because nowadays we see children who don't learn well just because they don't want to. Children we don't have motivation, the intrinsic motivation, what we call. So we see lots of children like this. So every point here is very important. And this impairment should be present for at least 6 months according to the DSM-5 criteria. And the prevalence is around 5 to 15% of school-going children, and it's more in boys. And there are some comorbidities which will come to it later. Okay, now coming to inclusive education, just going a little bit into the history. So it was very interesting to note that the principle of this inclusive education was adopted at the World Conference on Special Needs Education in Spain, and it was again restated at the World Economic Forum, and which says that children with special needs must have access to regular schools. So this was the first thing that the change that happened. And coming to India, this is a brief timeline of inclusive education in India, starting from the year 1974, where the first integrated education for disabled children was started. And there was a major happening in 1997, where the term inclusive education was introduced. And finally, as stated in the previous session by Dr. Usha ma'am, the new national education policy, also called the Shamagra Shiksha Abhiyan, was started in 2020, which brought a big change in inclusive education. So what are the key problems? So after starting of all these policies and implementation, what are the problems that we face in the field level? So that is very important, because whenever there is a policy made, it is made at this level of an IAS officer, but they don't understand what the field level difficulties are. So there is a lack of awareness among the public per se, and there is a delay in early identification, because we know that both in the schools, in the CBSE curriculum and the regular curriculum, all the children up to 8th are given a pass. So they don't, like, the parents are not able to identify whether the child has a problem. And after, when the child comes into a higher class, like maybe 9th or 10th, and then only they realize that the child is not able to cope up, and then they try to identify. So there is a delay in identification. And there is a lack of comprehensive support system, and always the stigma is there. And coming to the policy, there is a little bit challenges in policy implementation also, lack of diagnostic infrastructure, and deficiency of trained teachers. The resources is very limited. So now coming a little bit into the new education policy 2020, which envisions an India-centric education system that directly contributes to transforming the country into a sustainable and vibrant knowledge society by providing high quality education to all. So it has these 5 pillars of access, equity, quality, affordability, and accountability. And we have got very good results, which this, the data that shows 61% of children with disabilities between 5 to 19 years are attending an educational institution, compared to the dismal figure of less than 2% in 2001. So in the 20 years, a lot has happened, a lot of improvement in this field has happened. Okay, so coming to this SSA Samagra Shiksha Abhiyan, it's an integrated scheme which covers pre-primary to class 12, and there are many policies in this, like giving financial support and grants for AIDS, and girls with disabilities receive stipend. There are special educators at all school levels, awareness drives, and even home-based education for children with severe disabilities. And I happened to meet one of my schoolmates who is a special educator. So for this topic, as a part of my homework, I visited the school, and I just happened to see what is called the resource room. So in inclusive education, they have this resource room, which is set up in a mainstream school, which provides special assistance or training for a child with LD. So in this resource room, they have trained teachers and materials, and how much time this child has to spend in the resource room will depend upon the child's, individual child's needs. It's varied. And as the child gets better, they go to the, the regular class. So the time spent here will become less, and they go and join the mainstream. So this leads to better academic achievement and self-esteem among children with learning problems. Okay, coming to the, so we saw what is inclusive education and what is learning disability. Now coming to a different perspective, what are the comorbidities associated with LD, and what are the problems that exist in LD which makes inclusive education difficult? So the comorbid conditions are, like we already saw, ADHD, anxiety, depression, speech language disorders, autism spectrum, oppositional, defiant. And coming to the behavioral issues. So the behavioral issues in LD is a complex subject, and as you see, it has different aspects to it. If you can see, there is a low frustration tolerance in these children, which results in a disruptive behavior. They can't be sitting in one place for a long time, so they want to keep move around if they have an associated ADHD, or even otherwise, their attention span is very short, so they try to disrupt the normal class, which is a challenge to the teachers and to the other students. And they also have this inability to interpret the environmental and the social cues. And there is poor judgment, and they don't think about the consequences of their behavior. So they think they can do without thinking about the consequences. There's a poor impulse control, and there's a need for immediate gratification, inability to set realistic priorities and goals, and they come to inappropriate conclusions due to deficient reasoning, illogical reasoning, and inability to develop meaningful, the socialization, the social cues are little deficient, which makes it difficult for these children to get along well with the normal children. So with these secondary behavioral issues, what do we expect? We expect certain behavioral deficits that leads to challenging behaviors. So behavioral deficits, it could be an on-task behavior when the child is given a task in a class, the difficulty for him to finish the task on time, or if it is a challenging task, they find it difficult to do it. And if it is given, outside the class also, off-task behavior, and it leads to defiance and conduct issues, distractibility, which we already saw, and sometimes the children may be a little withdrawn and they get away from the class. So this leads to challenging behaviors like attention problems, hyperactivity, aggressive behavior, self-injurious, stereotypical, and sometimes socially unacceptable behavior. Okay, so what do we expect? It could lead to certain disorders. So the overlap between LD and behavioral is somewhere between 5 to 6%. It can present as externalizing behavioral issues like oppositional defiance, impulsivity, hyperactivity, aggression, antisocial, or internalizing behavior issues like withdrawal, dysphoria, anxiety, and depression. So it can be either. And coming to the intervention, so before the child, if the child is already in inclusive education, it's good, but if the child has grown up and has developed these problems, for him to stay in the inclusive education, we have to deal with these behavioral problems, which is very important. So what can be done? In educational, we can think about remedial teaching, multisensory learning, which I'll come to it in the later slide, and IEP, which is called the Individualized Education Plan. And behavioral-wise, it's also important in challenging behaviors. There are certain techniques called positive reinforcement, behavior modification, and social skills training. So coming to this behavior therapy, a short insight of what it means. So we all know that the COGS, cognitive behavior triad, consists of this thoughts, emotions, and the behavior, which says our emotions, what we feel, affects how we think and act. The first is the thought. What we think affects how we feel. What we feel affects how we think. And finally, what we do affects how we think. So this is a vicious thing which keeps, so we have to stop it at some point. So for the behavior, to correct the behavior, the thoughts and the emotions have to be controlled, which is very important, for which we follow the ABC model. So like we do that in adolescent behavioral therapy and counseling also. So for every behavior, we know that there is an antecedent. For example, when a child throws a tantrum or throws an aggressive, does an aggressive behavior at home, there should be an antecedent to that behavior. So we shouldn't treat the behavior as such. We should see what led him to exhibit that behavior and then deal with it. And this behavior will lead to certain consequences. So we need to find the antecedent and then deal with this behavior. Some children with severe behavioral disorders will need specialized psychologist to do the cognitive behavioral therapy. And again, we also have to give the psychological support in the form of counseling, and parent training is very important, especially for children with LD. The parents also have, the support from the parents is very important, and the parent-teacher communication, that is also very important, and referral if the behavioral disorders are very severe. Okay, now coming to the first question that is faced, which is inclusive or special schools. So in an inclusive classroom environment, all these things should be present or should be in the proper way for the child to excel academically. The first and foremost is the teacher. They should be trained, empathetic, with skills to handle these children, and they should have the regular knowledge update programs. And parents, they should maintain regular communication with teachers. As I heard from one of my friends yesterday, who her child, so she says that she regularly meets the teacher. So to keep up the communication, to know how the child is responding to the teaching methods, and special educators and therapists. Peer support, the buddy systems, what we call, which is very important because these children are vulnerable to bullying. So such systems in the classroom will help these children from bullying. And the curriculum design, which is called the universal design for learning principles, that is presenting information in multiple formats, like it could be a text, it could be audio, it could be visual for better understanding. And nowadays we have AI. So morning also, the first session, Dr. Emma sir talked about AI. So we have AI in everything. So maybe we can use it in a very constructive and productive manner for these children. The new methods like audiobooks and additional time and support. Like we can have breaks during the learning sessions, extra time, use of scribes, etc. So what are the pros and cons of inclusive learning? The social skills are better, the academic achievement is better, and the qualified teachers and resources are there, it's definitely an advantage. The self-esteem of the child, which is very important. Suppose if it is a special school, and so many children with so many disabilities are there, that becomes an obstacle to the child to develop a positive self-esteem. So that is a very important thing. Coming to the disadvantages, of course, because of lack of trained teachers or resources, there may be a lack of individual attention. And we have a standardized, rigid curriculum. So we have exams in this time has to be, exam has to be finished this time. So it's very rigid. So that may be a disadvantage to this child. And again, as I said, inadequately trained teachers and the potential for bullying, which is very important because as an adolescent physician, I have seen like 1 or 2 boys in the age of 13 to 14 who have been affected very severely by this bullying. They come with a lot of behavioral issues. Now coming to the special schools. So the pros, the children with comorbid conditions, as we talked about earlier, they may benefit. And also we could say that there is an individualized approach in a special school, which is an advantage. And coming to the disadvantages, again, what are the, in the special school, there are other children also with different types of disability, and there is a chance of social isolation and stigma, and there is a limited exposure. So in special school, the curriculum may be limited, so, and the academic expectations may be reduced. And when the child wants to transition from a special school to a mainstream school, there are challenges faced. So this is one main disadvantage. Cost is a big factor. Like many children from the lower socioeconomic status cannot afford a special school, and resource limitations also. Okay, so the way forward, NIOS, all of us know about this National Institute of Open Schooling. The inclusive education policy of NIOS 2022 removes the barriers to learning by adapting curricula. So it is curriculum, that is, it's not a rigid curriculum, it adapts to the children's needs. And assessment, instructional methods, everything is suited to the individual child's need. And we have some customized learning materials. It's very easy to apply to the NIOS also. There is a website, dedicated website. And there is a flexible learning model, flexible choice of subjects, self-paced learning. So it's not like a rote learning. So the child can choose their time of learning. And they can also concentrate on the other interests also, which is very important. And during the exams, they can use an extra time, scribes, breaks, readable formats, etc. And NIOS also collaborates with trained special educators, accredited special schools, and offer financial concession, occasion, and skills training. So I have presented both the versions, the inclusive education and the special schools. So how do we make a choice? Let's move on to 2 case scenarios. So here is a 13-year-old male child with SLDs in a mainstream school, frequent aggressive behavioral episodes at home. So on assessment, he's found to be bullied at school, as an impact of which he exhibits this behavior. So what will you advise for this child? So he's 13-year-old, he's exhibiting some aggressive behavior. So maybe we can focus on that behavior. So immediately we need not make a decision and move him to a special school. Maybe we can try to address that behavior by specialized counseling, and maybe a therapy with a psychologist we can try to do. And we can also talk to the school teachers to give him some support in school by the buddy systems that we were talking about, and also some support from home. And we can try and follow this child up and see whether he is improving. So just because he is like this, we needn't change. So we can continue the inclusive education. And one more case, a 14-year-old girl with episode of self-harm. So she's found to have SLD, which was diagnosed late and was constantly ridiculed for her poor academic performance. She had poor social skills and was not supported by her peers. And she's very much interested in badminton, but she had to discontinue. So what will be the advice for this child? Maybe NIOS will help this child because she has LD. So, but she's also interested in badminton, which is her strength. So as adolescent physician, we always do this SWOT analysis, the strength, we focus on the strength. So So maybe when she is in NIOS, she can also concentrate both on badminton and do her studies at her own pace. So she'll take care of both the needs because she's not a social thing, so the support from school will be less. So this is one option for her. And also she's come with an episode of self-harm, which means we need to assess her for any other depression or other diseases and follow her up. So finally, I would rest my case saying that the decision to choose a school for LD children is highly individualized. It's not that this for this or this child. So it is highly individualized. We have to take into account the child's needs, potential, comorbidities, mental or emotional health. So each one of these factors is very important in choosing a school for a LD child. And a multidisciplinary approach involving the parents, special educators, counselors, and the teachers is very crucial in this, the academic excellence of this child. So no one-size-fits-all approach will deliver the desired outcome. Thank you. Thank you so much for the patient listening, and these are my references. My special thanks to Dr. Sudhagar, Dr. Malege, all of them who helped me in preparing this, and it was very interesting to learn.
Mementos to the speakers. Now I request Dr. Devaprasad sir to hand over the memento to our chairperson. I call upon the previous speakers of the panel discussion to come to the dais. I request Dr. Jayashree ma'am to hand over the mementos to Shri Priya ma'am, Saranya ma'am and Usha ma'am. Now I request Saranya ma'am to hand over the memento to Jayashree ma'am. Now we move on to the next session. Our chairperson is Dr. P. Tyagarajan sir. Sir is currently Associate Professor of Pediatrics in Government ESI Medical College. He is a very down-to-earth person with a wide knowledge in the field of pediatrics. He has more than 15 years of teaching experience for UG and PG teaching. He is an active member of IAP and he has conducted several workshops and he has several publications in reputed national journals. Now I hand over the stage to Dr. Tyagarajan sir.
Very good afternoon to all. I think this session is going to be a little interesting. The first speaker, who is having more than 25 years of experience, Sudhagar sir, will enlighten us about the acute presentation of children with neurodevelopmental disorders. most of us are familiar with what is the typical presentation, a developmental delay, so many social issues, communication delay. But will they also have any acute problem? Will they come with acute presentation? And like you, I'm also interested to hear from him. Please come, sir.
Good afternoon to the audience. So most of my friends are sitting here. Support, mutual support for each of us. So being a developmental pediatrician, many times we wonder what we are doing with the autism, ADHD, LD. Other than that, we are not doing anything. So whenever in the conference, they always give a topic of autism or ADHD, LD. Myself started getting bored of that actually. Then please guys, please call me for something else. And they do whether you know anything more than that. So I have two books actually. An account of European settlement into America and into Africa. The two books are really books on expedition. Very interesting books. The first one is about Europeans moved to Americas, start migrating for money actually. They were digging golds actually. They thought America is full of gold. They started an expedition. Africa mainly for finding out the Queen Victoria Lake, an existing lake which the Africans are already there. These people are looking for the lake and finally they named it Queen Victoria Lake. So same situation when I was looking for emergencies in neurodevelopment disorders. I was searching for journals for this. I couldn't find even a single journal into publications into emergencies or acute presentation of neurodevelopment disorders. Then I thought, okay, what I did is right actually. So I'm going to present this a presentation not from the perspective of an emergency physician or intensive care. It is from a development pediatrician perspective. Acute presentation, this picture I always present is cortical thumb. For me, it is the first sign for, warning sign for development delay. A persistent cortical thumb in a newborn period in the NICU itself indicates of cerebral palsy or any other development delay. With this, I am going to, it's a case scenario. Audio. You put the audio. More than looking into that, please hear.
கூப்பிட்டா பார்க்கணுமா?
ரெஸ்பான்ஸ் பண்ணுவா சார். நம்ம பார்க்க ஐ கான்டாக்ட் இல்ல, ஆனா ரெஸ்பான்ஸ் பண்ணுவா.
இது கூப்பிட்டு பார்த்தீங்களா?
இல்ல
நீ கூப்பிட்டு வீட்டில் கூப்பிட்டு பார்த்தீங்களா?
So, usually from an emergency pediatrician perspective, you look more into the science and thing. From a developmental perspective, I want to hear from the mother. That's what the message. So for any acute presentation, we have that ABC, appearance, work of breathing, and circulation. So the baseline sensorium is very much important in cases. Always ask the mother, what was the baseline sensorium? Is it deteriorating from the existing baseline? That is very important. And always look for response to the pain. Children with developmental delay, especially cerebral palsy, they may not be already poor response to the pain. So don't make any decision based on two things without understanding what is the existing thing. And always have a high suspicion of shock, because all these development delay children, you have to consider them like a malnourished child, SAM children. They are almost SAM. And always look for metabolic and electrolyte problems. This is a special concern for children with neurodevelopmental disorders. So this case which I have played video is hypoglycemia. The child is presenting with a cerebral palsy presenting with a hypoglycemia. Simple correction of the blood glucose is going to change everything in this case. So when to suspect, say in the prevalence of neurodevelopment disorder comes around, it goes up to 13%, 2.6%, it goes up to 13%, varying places. Indian pediatric says 2.3 to 16%. So in daily, we can come across at least one case with neurodevelopment disorder, whatever may be the tertiary care actually. So what will be the clinical presentation? Sudden unexplainable sickness, uncontrolled seizures, acidotic breathing, abnormal odor, hemodynamic instability due to trivial factors. Mostly this is going to be a small molecular problem or inborn error of metabolisms. And always look for external anomalies, neurocutaneous markers, features. After securing the airway breathing and stabilizing, always look for things. Because because in ER what we do? We always been taught to look only into the physiology, not the pathology. After securing ABC, please look into pathology also. That is the message actually. Always ask for a development delay, unexplainable sibling death, and abnormal tone history. So now I'm going to present in a way, my presentation is going to divide into three things: a neonatal period and children, infant with development disorders of according to tone abnormalities, hypertonia, hypotonia, dystonia, then my own behavioral disorders. The newborn period, often three S's. We often come across children with seizures, shock, or sensorium change. Most common is within 24 hours, a neonatal period, within 24 hours, it is nothing but an HIE. After 24 to 72 hours, it is HIE as well as inborn error of metabolism or other metabolic conditions like hypoglycemia, metabolic problems. After 3 days to 1 week time, it's HIE again, then your inborn error of metabolism, then your other metabolic like hypoglycemia, hyperglycemia, then comes your infection. After 1 week period, all other conditions like infection comes to number one. So always whenever a baby with the altered sensorium or shock seizures, please think hypoxic ischemia, inborn or cerebral malformations also. So what is the neurometabolic presentation? In a newborn, we always expect a neurometabolic presentation. Whenever a baby present with recurrent vomiting, poor feeding or refusal, this more commonly happens in the postnatal ward rounds. A well-born baby, feeding baby, second day, third day, being in ICH, we often come across such situations. Vandanga sir, rounds edutanga sir, ketanga, paal kudikala. We always concern about breastfeeding. We teach, preach everything about breastfeeding. We forget the status of the baby. We always assume that mother is not giving the breastfeeding properly. We assume that breastfeeding is the problem, but the sucking is the problem. We have to look at the baby also. Many times being in the child development clinic, I have come across history of mothers saying that, sir, ரெண்டாவது நாள் மூணாவது நாள் பாப்பா பிடிக்கல, மூணாவது நாள் தான் வந்து பாப்பாவை தூக்கிட்டு நியூபார்ன் வார்டுக்கு கூட்டிட்டு போனாங்க. So we were missing the golden period. எப்படி நம்ம ரெசஸ்டேஷன்ல பண்றோமோ, எப்படி breastfeeding golden பண்றோமோ, picking up the neurometabolic problem on the second day and third day is very, very essential. Whenever a baby is not feeding, privateல என்ன பண்ணுவாங்க, எடுத்து lactogen or whatever it may be கொடுத்துருவாங்க. இங்க வந்து அம்மாவுக்கு அட்வைஸ் பண்ணிட்டு மூவ் ஆயிருவோம். We never think about the neurobiology. This is a very, very essential thing. So whenever a child is having poor feeding or refusal feeding in first 1 week, lethargy, dehydration, seizures, coma, please address to that. Think about neurometabolic because they are rapidly progressive, life-threatening, but if you manage in the right time, the child is going to have a normal life. And when you are thinking about inborn error of metabolism, neurometabolic, always rule out the other conditions. I occurs A, E, I, O, U, vowels. A, rule out asphyxia, rule out epilepsy, rule out infection or injury, rule out outside toxins, that's the drugs, rule out uremia or other hepatic encephalopathy. If these things are not there, please think about IEM. So differentiating IEM from HIE, hypoxic ischemic, usually they're never normal from birth. They're always having an asphyxia or some strain. Hypotonia, hyperirritability, HIE risk factors, all the HIE risk factors. Then IEM, usually it appears after second day, especially after feeding, proper feeding, and there may be a consanguinity and sudden unexplainable death in the siblings. So emergencies in neonatal period is the uncontrolled seizure is the so the metabolic disorders are rare but easily manageable. Seizures caused by IM usually present early and may not be responsive. This is another indication. If it is not responding for your regular anti-epileptic, think about metabolic causes. So in patients with persistent seizures, dystonia and focal nerve, always take a CS of, not correcting only is the problem, always take a CSF sample also and preserve at least 1 ml of CSF for later studies. And hemodynamic instability, small warning in the management. Fluid resuscitation with saline should be provided as necessary to maintain the adequate circulation. Oral has to be avoided. Administration of hypotonic fluids may cause cerebral edema. Ventilatory support should be provided as necessary when direct toxic metabolites cause respiratory depression, cerebral. So always think about, especially in the less than 1 month period, always think about all these things when you are managing an acute case. Coming to your neurodevelopment disorders with hypertonia, if often present with, there are causes for hypertonia is very extensive. So making it small, all hypertonia are going to have an intractable seizures due to hypoglycemia, hypercalcemia, hypoxia. This may be due to a poor nutrition or underlying condition, or it may be to a poor exposure to the sunlight. Just imagine, already all women are having hypovitaminosis D, and we are giving babies up to 1 year vitamin D, considering even though we are staying in the country with maximum sun exposure, we are having vitamin D deficiency. You think about a cerebral palsy when they are going to have a sunlight exposure. So always expect a vitamin D deficiency as well as other metabolic diseases. So choking is a very common thing. Aspiration pneumonia may be present with respiratory distress. Many times pneumonia aspiration pneumonia also can present with things presenting like a septic shock. And always expect a difficult intubation. The child may have a fall, joint dislocation, osteopenia, knee surgery. Whenever a child with a hypertonia, please look into all these things after stabilizing your physiology. Now I am giving a case of 2 years, 6 months old male child. He has spastic cerebral palsy due to HIE, brought to emergency OP with history of watery stools and vomiting, along with fever in a state of lethargy, neck flop and truncal weakness. Consider a spastic cerebral palsy baby presenting the lethargy, neck flop and truncal weakness. What are the complications expected in this child? So it is considered them as a malnourished child, severe acute malnutrition. I personally say every children with neurodevelopment, you have to look for SAM. And electrolyte is very common, and always look for the acid-base status for management purpose. These cases have a potassium hypokalemia of 2.4. The ECG says that inverted T wave and U wave and ST depression. So whenever you come for, please ECG, never forget to take an ECG. The electrocardiography ECG findings may include the following: ventricular dysarrhythmia, prolongation of QT, ST segment depression, T wave flattening, appearance of, you need not bother about the ECG, but it's good to learn through that ECG, and overcorrection should be avoided. So development disorder with hypertonia, do's and don'ts, always look for the underlying cause. Adrenoleukodystrophy may present with hypotension due to adrenal insufficiency, not to the circulatory problem. Hence on arrival, treat the child with inject hydrocortisone than rushing with fluid. So whenever come adrenal is again one of the common conditions, especially in the older children. That too, a normal childhood infant period, then gradually increasing muscle tone. Please think about the adrenoleukodystrophy. Never forget to suspicion of physical abuse, a very common thing. Never miss to look for electrode limit. Never forget to ask for drug history. Most of the time they will be taking anti-epileptic and many other drugs. Nowadays the pharmaceuticals, nutraceuticals, we are supplementing with nutraceuticals. Often I don't write much drugs actually, but I'm seeing at least 2 or 3 drugs for every autism, hyperactivity, learning disability thing. And I'm sure that prescribing physician also may know or may not know what he is actually. And we don't know what is the side effects are. We are still following the pharmacy people, what are they are telling. We really don't know. They say it is safe, that's we are also saying it's safe. We are not yet studied that actually. So we have to be very careful and never hesitate to call for expert opinion, especially as well as anesthetist opinion is very, very essential in these cases. So now we come to the NDD with hypotonia. So we know what is the hypotonia, may be a central hypotonia or peripheral hypotonia. In emergencies, always look for a peripheral, more importance to the peripheral hypertonia, because central hypertonia is going to present like a tone hypertonia patient actually. So problems related to hypertonia, aspiration is the #1 causes for aspiration pneumonia, going for sepsis and shock and everything. They need a prolonged ventilation compared to a neurotypical children. Very difficult to wean from the ventilation. Infection, malnutrition, seizures and associated cardiac anomalies has to be taken care of them. So cautions with infants hypertonia, non-invasive ventilation, awake ventilation, RSI, will talk about it actually. See, this is the picture of thing. Child with a problem in the respiratory problem, whenever the respiratory load is managed with the respiratory muscle capacity from the central drive. In a child with hypotonia, when there is a compromise in the respiratory muscle, it's not able to manage the respiratory load, the disequilibrium happens actually. Your central drive also gradually going to come down. So the non-invasive ventilation has to be early, it started very early when compared to a neurotypical children. So I'm skipping that. This is the RSI. In RSI, I don't want you to go through all the lines actually. The second line, identify condition that will affect the choice of medications. And then pre-oxygenation. In hypotonia, we need not paralyze actually. Most of the time, especially SMA, awake intubation, the child is not going to paralyze. Why you have to paralyze the child? It is going to have a difficult intubation, you have to paralyze the child. In floppy children, especially in SMA, there is no need. Awake intubation is the #1 choice actually. So drug choices, succinylcholine should not be used. Of course, we don't use it much nowadays. We have the choice of last line, rocuronium, and always go for, this is for muscle, Sugammadex is the, nowadays Sugammadex is easily available actually for, this is the line, where is it? The last paragraph. So Sugammadex is the drug being very commonly used, thanks to my wife who is an emergency physician. She only taught me all these things. I don't know anything about this. So apneic oxygen and ventilator association, very essential for these children actually. Nowadays, previously what we do, in my days, of course in my PG days, we ventilate for a minute, then we started intubating it. So for children with this compromised respiratory muscle, always go for apneic oxygenation or VAPOX ventilation, pre-oxygenation. So the oxygenation is continuing because already the tidal volume is very low, so always continue the oxygenation and continue your intubation. So development disorder with hypertonia, always look for underlying cause, never forget suspicion of physical abuse. Now come to the dystonia. Dystonia again is one of the very important, we may not see much cases like hypertonia and hypertonia, but most of the time in CDC I have come across dystonia being managed for cerebral palsy for many years. Very unfortunate actually. So dystonia, the presentation is acute or tardive or paroxysmal chronic progressive. A case scenario, a neurotypical children, 18-month children, vomiting and fever for 3 days, managed as OP, given medication for presenting with the abnormal movements, nothing but it is for time, want of time, I say, there is no other medical history, medical illness, medical history leading to anything, a normal child. So what could be the first differential diagnosis? Yes. That's why the vomiting. It's simple, very common. First case when I was very young, a High Court lawyer brought his child for that. You just imagine, High Court lawyer brought it. He was telling that my baby is having seizures, and I fed that what are the drugs you have given. They did domperidone. After that, I never touched domperidone out of here. Yes, sir. So I don't want to go to the drugs. So drugs is the main important. Always acute dystonia. Always think of it. So case scenario 2. So the precipitating factors will be emotional stress, fatigue, viral infection, hypocalcemia, all these things. And dopamine, sorry, your answer is there here. Case scenario 4, it's a neurodevelopment, a 7-year-old boy managed with autism and ADHD with multidisciplinary therapy. Since he is showing many impulsive activity disturbing children, started on the medical management. He started, see, autism with ADHD, when you started managing autism, the unmasking of ADHD started happening. Can I get me one? So the child started having more ADHD, so they started on drug, the child started having a problem of dystonia. Let us be directly go to dystonia. Now the drug has been stopped. but the symptoms continue. What I have to do? This is a case, dyskinesia. You can at zero SSRIs and all the other antidepressants, they take at least 1 month to come out of that actually. So need not rush with anything. Wait for, meanwhile start the tetrabenazine. Another condition is called paroxysmal dystonia, familial, kinesthenic, exercise-induced, hypnogenic. So this is familiar, these are all chronic conditions recurrently coming. Kinesthenic, when sudden movement is there. Exercise-induced, whenever the child do an exercise, he gets dystonia. Hypnogenic, another peculiar situation, I have not seen any case. During sleeping only the child gets dystonia. The treatment is nothing but clonazepam, carbamazepine. And chronic non-progressive dystonia, these are considered as a primary and secondary. Among the primary, idiopathic, dopa-responsive dystonia and diurnal. We have seen dopa-responsive dystonia during our PG period commonly. And secondary, it is congenital hereditary and metabolic causes. And dystonic storm, I will be skipping that. Behavioral disorders. Autism, anxiety, depression, conduct disorder can present in acute presentation, especially children. Aggressiveness due to sensory issues, they have a lot of aggressiveness, self-injurious behaviors, drowning. Electric shock is very common. See, children with autism, they'll be keep on roaming, they always have a fancy about switching. They'll be keep on playing with the switches. Road accidents, many times, say in my own center, kids just like they run to the whole road actually. Now we have put an electronic gate and everything. So this can happen. Accidental sharp instrument injuries, accidental direction. I got a baby with Tyronam tablets, almost 20 tablets, swallowed 20 tablets. So carry home message, always look for a basal sensorium level, look for shock and dehydration in any child with development disorders. Salbutamol and acidotic can be lethal in cases. Never miss the history on muscle tone. Be very cautious on using the muscle relaxants. History on drug intake, because they'll be on multi-drugs actually. Don't forget to look for anomalies, especially the trisomies. They'll have a microstomia, large tongue, cleft palate, everything is there. Craniostenosis, just imagine mid-facial hypoplasia. Always look for all these things when you come across a child with a development delay. Never hesitate to call for an anesthetist who are good in intubation. Never forget to think about child abuse. Thank you very much.
Thank you very much for the wonderful talk, sir. Actually, this is a very rare topic. Most of us don't have a clear idea about this. And this is really very much enlightening your talk was. And we had also a personal experience. Most of the time when the mother complains about babies not taking feed, especially primary mother, most of us tend to blame the mother only. We don't look into the other issues. Suppose baby might be having the problem. Really, the point is well appreciated, sir. Thank you very much, sir. And we are going to invite the next speaker, who is Vijayarani madam, who is having more than 25 years of experience in adolescent care to enlighten us about. This is one more interesting topic, useful topic for the practicing pediatricians. Nowadays, we are seeing less and less infectious cases. What we are facing is nutrition related, the obesity, and related to various health issues, including sexual health, how to deal with them. We are eager to hear from you, ma'am. Thank you, ma'am.
Given a chance to talk here. Thank you. Sexual health in teens, practical counseling for pediatricians. So right from the morning, I had been hearing a lot of high-tech matters, then on breastfeeding, lactation management, and of course, we heard here about the left ventricular failure and how to, the ticking time bomb, etc. So what is it, we are talking so much about breastfeeding, which is a very normal phenomenon, and so much has been done, and now we have to call up parents and teach them how to feed. The issue is we have brought down the mortality rate very much. Morbidity and mortality has been brought down by learning the right method of lactation. So is going to be the sexual health of teens. The time has come that we need to talk about sexuality and sexual health to our teens. And pediatricians have a major role in hand-holding our teens, because right from newborn period we are treating them and the parents come with them. They move into different phases, and suddenly in the teen phase, when they are really, really healthy, they kind of meet us less. But still there are areas which are of concern. You saw the problematic internet use. What are all, though they didn't go into the depth of what is the content of the problem, there needs to be a more into the sexual health where we need to talk. Teen sexual health encompasses physical, emotional well-being related to sexuality, decision making about sex, and understanding the risks like STIs and unintended pregnancies. Yes. So it's not just about the male-female gender, not about romantic relationship or just having sex. It's much more the feelings, the thoughts, and the repercussions of it, and what we are going to do, the behavioral aspects of it, and how are we going to bring about their ignorance, alleviate their ignorance. It is crucial for the adolescents to access accurate information and resources to navigate these aspects of their lives responsibly, and who else is a much better person than to communicate this accurate information. So the key aspects of teen health will be like understanding the sexual development. So we start early. Already we are talking about a lot about good touch, bad touch to very young children, and in school age group also. So now is the time they must be spoken about the bodily changes occurring during puberty, starting with menstruation and menstrual health. And then in the boys, we need to talk about self-stimulation, nocturnal emission, etc. And then what to anticipate regarding their height, weight, and then the development of the organs inside, and what could happen during this phase, forming relationships. We mean healthy relationships, and making responsible decision. We have to include the adolescents into this, give them the information, and they need to take responsible information. And what is the responsibility during this period? Access support and resources. We saw so many resources that is being given to the parents as well as the children. And we need to give it through schools or through the media or through any community services, and also in our clinics when they come to us, and start doing anticipatory guidance, understanding the STIs, what are the repercussions of these relationships, and what is an infection in this reproductive age group, and how are we going to deal with contraception and pregnancy prevention, especially now POXO is there. Are we going to talk about contraception to the children? So the key health areas, they are not very rosy, and regarding the reproductive health, 34% are unaware of menstrual hygiene and what can be the fallout, and 12%, we are already seeing adolescent pregnancies. These are reported cases, and definitely if you're going to block through laws, there's going to be unsafe abortions. Sexual violence is ever increasing. We have plenty of studies to say that violence is violence in partnership, and then abuse, aggression, all these are increasing, and about a lack of adolescents are getting infected by sexually transmitted infections every day globally. How are we going to treat them? Where are the resources for them? Apart from dealing with mental health, academic pressure, and nutrition-related social stress and chronic illnesses. Okay, now that we are ready to talk, but who are the people whom we are going to see? So they are the Generation Z, and maybe some of us will be teased for being boomers. They are entirely different. It's not totally dark too. They are people born between 1997 2012. They're very pragmatic, realistic, and they are all self-driven. It is more positive also. They're very collaborative, diverse-minded. We kind of already, our social makeup is that we are groomed to be in a particular way, values, morality, etc. But they are very open-minded. They are very globally connected and open-minded. They are flexible ambitious self. Because they are ambitious self, they are also anxious about self. Sexuality is influenced by, definitely by the social media because they are digital natives. You also heard about how even the adolescents, not just the adolescents, much earlier they are looking into the social media and how it is going to affect them mentally and what they expect of out of their sexual health. They have greater acceptance of LGBTQA sexual genders, and now the pediatricians will have to equip themselves to know a lot about LGBTQ community as well as how to be open-minded like them and handle them. There is a shift from traditional norms marked by greater openness and fluidity. By fluidity, I mean that they have better society norms and they are in open relationship. They are able to accept different types of sexual orientation and gender identity, and they explore their sexuality without any pressure of committed relationship. That does not mean that our adolescents are going to be having multiple sexual partners so easily. It's just that there is an acceptance. If somebody does that, they are not going to stigmatize them. What are the challenges? Of course, we have the hormones, estrogen, progesterone, and testosterone, really starting off the early sexual activity. The puberty is set much earlier now, especially girls. We actually have to reset the precocious puberty year. The neurobiology, so much was spoken, and the one point to be remembered is the older system, the limbic system is mature at the time of adolescence, which is very emotional, and they are very risk-taking and pleasure-seeking. Whereas the prefrontal cortex of the frontal lobe is yet to mature because the brain matures from occipital to frontal. So it takes some more time. We need to wait for the executive functions of the frontal lobe to wait, prefrontal cortex to happen, and the controlling force and decision making, problem solving, all these things need to happen, whereas the emotion is charged very much. Neurophysiological differences, whatever they are feeling, they feel like it is not without any problems. They are wearing the bulletproof dress. So nothing will really harm them. These high risk taking behaviors, what we perceive is not the same as for the adolescents. And also the peer pressure, it was there for us too in those days, but it was in a focus areas like academics, etc., or maybe in sports. Now it is different. They have to really, really fit into the groups, and otherwise they will be alienated. So there is extreme peer pressure, and physical relationships, it is different now. We need to talk more about consent and boundaries. So these will be the areas of major challenges with regards to sexual health. And media influence, you are having everything in your hand. The adolescents are having everything. They can watch everything. They can know everything. Only is that the brain is not really mature enough to take in those things. And they are vulnerable for sexual exploitation, aggression, and violence. Need not say we have been seeing this for almost 10 years. Slowly it has exponentially increased the violence. And what is coming to surface is only what is being reported. Most of it is concealed, and we need to talk about it more because you will already be seeing in your clinics. The most important part is mental health is an integral part of sexual health issues. Something happens to their sexual health, then it reflects in their mental health also, like anxiety and depression, and there are other disorders too. It is very important that non-availability of sexual and reproductive health services results in unintended outcomes that could have consequences for their mental health, and we need to play a bigger role in it. So how do we start? Before counseling, we need to take this HEADS assessment. This is a screening tool. It's a psychosocial review. It's an interview with the adolescents. Adolescent will be your patient, and you need to talk to adolescent in private to get history under these headings like home, education, eating, activities, drugs, sexuality, suicide, and safety. It is for convenience. There's one more thing called shades, which is strength-based, where you can know the strengths much earlier, and also school activities much more. And the resilient factors, which later on you can build up while counseling the adolescents. Yes, these are the essential what we need to follow. Privacy and confidentiality. Without privacy, no adolescence is going to come back to you. We need to maintain confidentiality, and we need to tell them the confidentiality rules, that in certain circumstances we will be telling the truth, whatever the fact, to the parents, wherein there is danger to the adolescents per se in suicide, or to other persons, like maybe if the adolescent is aggressive or not. In certain areas, we need to have combined sessions, like in eating disorders. And we need to give alone time. When we are talking to the adolescent, let's not be judgmental. If you are being judgmental, again, you yourself are going to give a lower self-esteem, pull down the self-esteem of the adolescents. And they may think, like they say boomer, they may think this doctor is outdated or old-fashioned. And empathy, I very much believe that empathy is really, really a great quality of every pediatrician. They already have it. And we need to have much more, because the adolescents are more sensitive, and we need to put ourselves in their shoes and see, especially the present generation. Effective communication, of course, that is going to be the backbone for our counseling and practice. So we need to verbalize, and that verbal communication, in younger age group, it was more of talking to the parents and also the child, whereas it is going to be less of talking. We do active listening, and our non-verbal communication, how we are going to see the adolescent, eye contact, smile when necessary, listen patiently, not showing our emotions. Our judgment should not be reflected on our face, etc. And we respect the adolescents. So small things can be done in your clinic, like height, weight, BMI centiles, already there in our websites. SMR charts, sexual maturing scales, Tanner stages. We can also have charts on breast self-examination and testicular self-examination. Very important, start doing this in our clinic, and orchidometer. So whenever the adolescent comes for immunization or any small injury or something like that, we can start anticipatory guidance. And in a small way, just inquire about their scholastic performance, or how is it at home, coming with mother, how is your mom, how is your relationship, like that. Then slowly we can move on. And definitely we need to use other screening scales. If we see the adolescent, and then if we do a heads assessment and find them to be low or in any one of the areas, we start using the screening scales like Beck's depression inventory, or priors like in problematic internet use, or scared in anxiety. There are many, many, all available for us. And always, like Sir said, how we cannot have the child to ourselves, we need to network. Similarly, in adolescent practice, we need to network with psychiatrists, psychologists, special educators, remedial coaches, occupational therapists, and also gynecologists. So we have a teamwork that must happen. Yes, before we move on, just a small case. Rahul, aged 13 years, speaks to his doctor about his concern being short in the class, and that even girls are taller. Can the pediatrician alleviate his concern? Definitely yes. So we need to know about these stages, early, middle, and late. 10 to 13 years is early. SMR, they will be in SMR 1 and 2. And the peak height velocity is in the first early stage, it's more for the girls, and in the middle phase, it's for the boys. So that is why Rahul is not tall. And it is because he says the girls are even taller, because the girls start early, and then once the puberty strikes, then their growing ends are fused. Growing ends of the bones are fused, and their height is reached. Whereas for boys, it goes beyond. So with these, in your counseling, with these instructions or advice, you can say you can still wait, but please come for every 6 months height recording. so that we don't miss out on other things like constitutional delay or any other medical causes. Again, by late 17 to 19 years, SMR 5 must be reached, and there is consolidation of the sexual identity. Also, there's sexual feelings, there's sexual interest. The interest is more during the early adolescence, whereas it goes beyond that during middle adolescence, where there is more of experimentation and the sexual drive is so high, and that is when they may go for physical intimacy, and also the question of sexual orientation comes. We can use this window framework approach for decision making. So just like we tell about good touch, bad touch, depending on the age appropriate thing for smaller children, then above 6th standard like that, we can start in pre-pubertal age group that about sexual attraction to the opposite sex or same sex, and then what all can happen and what it is normal, and what can be the repercussion if they kind of cross the boundaries, what are the health and safety measures, what is their privacy and boundaries. Every stage we can go, we need not tell everything at one go. Each point can be, each visit can be used for making them more knowledgeable in these aspects. Consent and respect must definitely be spoken about. And what are the repercussions, illness and protection, and relationship? How are we going to maintain a healthy relationship that is more enjoyable and safe? Okay, Rekha confides to the doctor that she is attracted to Anish and she takes all opportunities to be with him. She feels very guilty about it. This has distracted from her studies and her grades have fallen a bit. She's also worried about her parents, whether they would accept it. Is it a bad thing to have a relationship like this? So if we are not going to talk about openly with the adolescent about this matter, all the time she'll be thinking about the boy, Anish, and she will be distracted from her studies. Also, sometimes it can give anxiety, and suppose there is a problem in that, she may go in for depression. There's so many things that can happen as a fallout of this. So it's high time we also talk to the parents that all these attractions are natural. Nowadays, many parents are accepting, and actually the friends come, they visit each other's homes. All that is so acceptable. And we also need to express that what is infatuation and what is love, what is consent, that nobody else can touch their body without their permission. So, however, what is critical is how we apply the criteria and framework we have learned about while making decisions about love, relationship, physical intimacy, and how these are based on parameters of health, safety, privacy, and concern, and relationship. It's very important. We need to talk on this. And we also need to tell the boundaries, especially the physical boundaries, emotional boundaries, digital boundaries, they have spoken, social boundaries, how much time they can stay out, with whom they can move, how much they can permit others to touch them. Again, we need to talk to our boys about nocturnal emissions, self-stimulation, and pornography. Many of you know these are all biological processes, but a word about pornography, that it is not normal now. It is not a normal passage of adolescence. We need to talk more about it. It is becoming harmful, and more it can end up in the digital addiction. Again, we need to talk about gender issues and teach whenever there is time, we need to tell them about how to say no to any pressure on them. POXO is very important. Any abuse must be reported by the pediatrician or any examining physician, and the helpline is 1098. We have to do comprehensive sexuality education in all schools, which is the need of the hour, and teach them life skills, 10 life skills that has been promoted by the WHO: self-awareness, effective communication, problem solving, decision making, critical thinking, creative thinking, coping with emotions, and coping with stress. It can be applied in all spheres. And sometimes we can use, when we are in a busy OP, we can use these tools. like dialogue starters, visual learning. You can have small video clippings which you can show it to them, or you can give them resources. Go into this and see, or your own websites you can create and tell them, I have written about this, please watch this. So, and we can do scenario practice when they are there with us. So let's, as pediatrician, continue our journey in taking care of our children up to 18 years, not just stop with the treating of medical illness. Thank you very much. Thank you, sir.
A lot of thanks to you, ma'am, for enlightening us about this important topic. Adolescent health, especially the sex-related health issue, that's a very big issue for practicing pediatricians. Yes. Most of the adolescents, when they come to the clinic, they have a prefix idea, we are all boomer uncle. They always have this idea in their mind. Whatever advice led to this, they are hesitant to ask. Recently, even our own kids, they also have that idea, isn't it, ma'am? Okay, so you have clearly shown a very good thing, ma'am. Thank you very much, ma'am. Thank you very much.
Now I request our chairperson, Dr. Tyagarajan sir, to hand over the mementos to the speakers. Now I request Dr. Sudhakar sir to hand over the memento to our chairperson. Thank you for the wonderful session. Now we are moving on to the next session. I introduce Dr. Balamal Sujata ma'am. Ma'am is currently Professor of Pediatrics in Panimalan Medical College, Hospital and Research Institute. She has done her post-graduation in the prestigious Institute of Child Health, Madras Medical College. She has more than 12 research publications, and she is the associate editor of the one-day series, which we daily see. Thank you, ma'am. Now I hand over the stage to you.
Good afternoon, everyone over here. So the next session is about public health and private practice. Two sides of one mission. So at a glance it looks like public health and private practice, they are totally distinct entities. But when we look at it closely, they have common goals, which is about an improved child health and well-being. So I would like to call upon Dr. Johnson Reddy to share his view on public health with regards to child health.
Sujata madam, I thank the organizer for giving this opportunity. I thank each one of you for being patient and toward the fag end being present for this topic. And I am working in a government setup. I do practice also, but I will be talking more about the government setup and how all the programs run. And in public health, what is the public health? Normally, because still in India, most of the patients, they go to government setup, and we cater to more people than private setup. And especially poor and those cannot afford private setup, private hospital facilities, they come to government setup, where we have to give justice and we have to give the best possible treatment for them. And even though we may have sometimes resource for sometimes some drugs they may not afford, or it may not be available in government, we somehow adjust and we should and give the best for the patient. In public health, what is public health is defined as the science and art of preventing disease. So prolonging life and improving the quality of life through organized efforts and informed choices of society, that is, or organizations, communities, and individuals. Public health can be small handful of people, or a village, or an entire city. It is the concept takes into account not only physical health, in psychological, like our mental health, also very important part of our health, and social well-being. As such, according to WHO, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It is not only infections. So we have to other things also important in complete health. So the key aspects in public health include disease preventions. Identifying and mitigating the spread of infections is important, because like as COVID we knew. So how to first we didn't know how it causes. Then we understood how what the agents, then how it spreads, then what to do. Then we found out the cause, then what treatment. Then we initially we didn't know what to do. Then we learn. So like that in public health it's like stepwise. So we know the cause, then first mitigate. If still disease comes, we have to treat. And when it is a chronic disease like diabetes, hypertension, or cancers, where what to do, we have to intervene. Health for everything, health promotion. We have to have a good healthy habits. From our side, we have to do something like eating good vegetables, fruits, and balanced diet and exercise. Good night, vaccination against the commonly vaccine preventable diseases, and that all will help in improving the overall well-being of the children and future adults and the community at large. So environmental health also important. Like in winters, we see Delhi people, they suffer from so many wheezes and other complications. Whenever there is a cold weather or so much of allergens in the environment, and in summer so much a dusty environment, and so you see so many people suffering in Delhi. So the environment is also important contributors for our health. Similarly, our air quality, our water, sanitation is not good, or water quality is not good, so like diarrhea, cholera, so those diseases will happen. And occupational, when some industry is there, so there also we have to take care of their workers' safety and their health. Similarly, we should have a good health policy. Unless we have a policy, what to monitor, who will check, what are the guidelines. So those things we should have, government should have a policy for different aspects of public health to improve the overall health of the population. Similarly, like tobacco use, food safety. So for food safety, there are some different guidelines. So there are markings also whether that meets the quality, and then there is access to health care. So in important part of public health is that like surveillance. If you do surveillance, if you search for the disease, then only we'll get. So that data will help us what is the prevalence of one disease, or what is the severity of the disease, or how many people are suffering, what is the mode of spread. So if you do surveillance and monitor, so these two are important parts. Like in all our states, IDSP is the important portal where we see some new disease or new manifestation, new problem. Immediately we report to the IDSP. So then they will investigate for the cause, and they will report to the government. So where government will send the concerned people and investigate for the exact what caused the disease, and we identify and we treat. Like in Kerala, you have so many viral diseases coming up. Unless somebody doesn't inform to the government, so slowly, small endemic area become a pandemic. It will become a pandemic. So that's why surveillance is a very important. So emergency preparedness and response. For any emergency, we should be prepared. Like COVID, we are not prepared. So so many people died because we could not provide them ventilator or basic oxygen support. By the time we developed all those things, COVID was almost half over. So we should be always like develop the strategy for emergencies, pandemic, and natural disasters. In public health, there is four important factors. Other one is surveillance, as I already told. What is like there we see what is the problem. Then risk factors. What is for that disease, what it is causing. Then evaluation. What works for like which treatment is best, how it is manifesting. So what to do. So we should know. Then implementation. Which drug to give, or how to control that disease, or whether it is an infective disease or it's a airborne disease. Depending on the cause, we have to treat. We have to know the problem, then our response will be based on the problem. Then in public health, there are core indicators are prevention, then epidemiology of the disease. We have to know the incubation period, that is a pathogenesis, clinical manifestations. Then only from where that pathogen will come. So then we can, so if it's a respiratory disease, we'll take throat swab or chest X-ray or PCR. So like that. Then lab we can confirm, then information. So regarding that disease, we have to have information, then only we can treat with the proper drug. And then it's a surveillance again, because we have a surveillance, we find the disease. Once we find the disease, which is the best way to diagnose and confirm, then we go to the lab, and we have to develop the lab of for the diseases. And like COVID, we developed so many places, even small PSCs or even Anganwadi centers. We were taking throat swabs, and we used to do PCR and diagnose. So because it's a pandemic, so similarly we have to, for every public health problem, we should have a like broad knowledge. Then only we can be focus on the disease. So 3 core functions of public health is assessment, systematically collect the data, analyze the data, make available information on healthy communities. And policy development, so promote use of a scientific knowledge. Once we collect the data, then we have to make a policy. Then third is assurance, ensure provision of services to those in need. So those who are in need, we have to provide all the facilities. And then there are key aspects of national health policy. Universal health coverage. So important part of national health policy 2017. So here you have to provide all citizens good quality health regardless of their socioeconomic status. Focus on prevention, because this is more easy and cost effective measure. Once we focus more on prevention, it emphasizes preventive health care measures, including immunization. Like COVID, how we controlled. When we all vaccinated, and by the time community had more than 70% immunity, then we can automatically block the spread of the disease. So immunization is an important component of any infectious diseases. And health education. So unless we behavior change, proper use of mask, hand washing. So in that way we control. Similarly, that helps us to reduce the burden of the disease. Tackling of NCDs in government, there is a program of diabetes and heart disease prevention. We are running NCD clinics in PSCs, even Anganwadis in Pondicherry. We are in Anganwadis also. The NCDs, they are providing all the medicines. Sometimes they go and give the medicine at home. So then strengthening of the public health systems, focusing on infrastructure, human resource. So doctors or healthcare workers frequently should be trained about, because they are seeing the ANM is seeing so many programs. So we have to educate them about the different programs. So we have to update their knowledge. So in that way, that benefit will go to the patients, and also they will red flag anytime any problem comes. They can say this area this is happening. So unless they are educated, so we cannot, because they are the last points of our health delivery system. Then increase in public health expenditure. India still uses very less amount for health, our budget for the health. So it should be increased so that we give the best care to our public. Integration of Ayush. Recently, the Government of India has issued an order to integrate Ayush with MBBS for JIPMERs. So there is some protest that went on. So still after that, I think government will hold back. So similarly, regulations and standardization. So we have to have a proper regulatory body, so that everything like drug manufacture from drug quality or everything labs, everything there should be proper regulation should be there, so that they get the best test possible or best medicine possible. Other notable aspects of India's public health is Ayushman Bharat Yojana. This is a very good initiative where the poor people, they get Ayushman Bharat card. With that card, they can get the best treatment in any hospitals. Up to 5 lakhs, government will reimburse. In my hospital, we have so many deliveries. Every day when I sign for those bills, so we feel happy that we are generating so much money. Few lakhs every day, few lakhs we are getting in a government setup for the patients. But still, we are not able to use that thing for the public patients, because there are so many loopholes in spending in government. You can earn money from the patients through Ayushman Bharat, but once you want to spend something for the benefit of the patient, it's very difficult. It has to go through long process, where by the time one warmer comes, so it will take 1 year. So these things we have to streamline, and because this is a very useful thing, still so many people, poor people, they don't know that they can go to private hospital and get treated under Ayushman Bharat. So once they are aware of this thing, in private hospitals also they will have good income also, so our patients will be distributed equally, so that they can get the best. Then there will be competition between the government and private. So government hospitals also will give private level of treatment to maintain that patients and give treatment under Ayushman Bharat. So in that way, we can improve the overall infrastructure and other medicine and other aspects of government in government hospitals also. And in the National Rural Health Mission, this has been a very big boon for the health, because in government setup, we have to recruit a doctor. It takes very long, especially in UT like Pondicherry. It takes very long, because every class 1 and class 2 officers has to be selected only in Delhi. It takes a long process to recruit. Whereas in NHM, you can take any specialist with a just small notice, and you can call interview and select. So you can, wherever you have loopholes, wherever some lacuna of the specialist, you can easily get, so that we can give the best care to the community. So we should have a decentralized primary health care. So because it's not only in big hospitals, the community health centers also should be developed, so that their specialists are available. So you give the best possible treatment in community health setup. Then PHCs, the most of the whatever their level they can manage. We can give the proper medicine in there, so that they can treat. They need not come to tertiary care hospitals for just URA or viral fever. So in that way, we can decentralize. What are the challenges? Despite India's progress, public health system still faces challenges. In especially South India, we have a better government setup. We give the best possible treatment. In North India, only few institutes they give. But if you go to Orissa or Bihar and all, so there you see they don't have any faith in government system. Most of those who can afford, everybody will go to private hospitals. Only during emergencies only they go to government hospitals. In South India, we see in Pondicherry, we have like MLAs, daughters delivering in government setups. So that we can't see in North India. So in that way, we are better compared to other parts of India. Still, we can develop and we can improve in government setups. The policy strengthening a public health system, improve the overall health infrastructure, and addressing social determinants of health to achieve our goals. And COVID-19 has taught us a lesson to improve our health infrastructure and keep sufficient health staff in different setups, so that whenever emergency strikes, we are there to act and give the best treatment for our people. So one more important program of Government of India, RMNCH plus. We know RMNCH we used to study. Now plus A is for adults are also, treatment also included in this program. So reproductive health of mothers, maternal health, newborn, child and adolescent health. With the plus A signifies the adolescents also important component of the society. So for them also for their diseases and their treatment also we have to give special importance. So reproductive health, what we see, family planning services to the mother, safe abortion practices. For maternal health, antenatal care, safe delivery practices, and postnatal care Postnatal care also, even if they are delivering in government hospitals also, postnatal care also now they are giving very good care. They are being paid for delivering in government hospitals. So many benefits are there for the mothers. Similarly, newborn health, essential newborn care. Now there are so many SNCU and NVSUs are developed under NRHM, so that they are trained people are there, and immediately they are providing all the like facilities like ventilators and pulse oximeters and other provisions, oxygen provisions, so that we improve the health in the peripheral hospital, so that tertiary care hospital is not burdened with all sick babies. And now the new concept, home-based newborn care, whichever is managed, can be managed at home also. We can have a follow-up with the doctors at the nearby setup, and the patient can be seen at home, baby can be seen. Similarly, child health, the important of children immunization, management of childhood illness, and during diarrhea, ORS and zinc and respiratory disease control programs. And for adolescent friendly health services, and most of the PSCs nowadays, they are running adolescent clinics, because they don't fit into medicine OPD or nor fit into pediatric OPD. So their problems are specific. They will come with acne, they will come with some emotional problems. So that type of problem, somebody trained in that adolescent physician can help them to solve their problem. So what many diseases are under control under the NRHM. So many programs are there. Previous National Vector-Borne Disease Control Program, leprosy elimination program, tuberculosis elimination program, IDSP. So the National Mental Health program, National Program for Health Care of the Elderly. For geriatric population also there is one program. So NCD also we have a program running in PSCs. Similarly, for deafness also there is one program. Tobacco control and drug de-addiction problem. National oral health program. Dentists will visit the villages with the mobile vans, and they see the children with the dental caries or other problems they treat at home. So this is a part of dental health program, oral health program. Similarly, national program for prevention and control of fluorosis in endemic areas, not in all the areas. Similarly, iodine deficiency disorder control program. The newer things are organ donation transplant program, or national program for prevention of and management of trauma and burns, and palliative care. Thank you very much for your patience.
Exhaustive talk on the public aspect of child health, the various policies there. Thank you very much. Now I call upon Dr. Jyoti Lakshmi to give her views on private practice and child health.
Thank you, ma'am. Good evening. And I think after listening to that talk from Dr. Johnson, you would have known about the government part of whatever. I'm a pediatrician who's working in a private medical college, and I do my private practice. So that doesn't mean I don't have a social commitment, or I don't have to think about anything that is happening in the society, okay? So the next 15 minutes of this talk is basically how, as a pediatrician who is working in a private sector or who runs her own clinic, how are we going to incorporate our services into the community? So that is going to be the gist of what I'm going to talk for the next 15 minutes. So public health and pediatric practice, 2 sides, 1 mission. That was the heading that was given me by the organizers. And they told me, ma'am, you will be representing the private sector, and we have somebody from the community pediatrics who will be talking about that. Sir has enlightened us about a lot of things which the government is doing for our children. Let me also say the role is the same. So public health and pediatric practice are intrinsically linked. You cannot say, I'm in a tower and I will look at only the people who are coming to my tertiary care hospital. I've got nothing to do with the social pediatrics at all. That's a very wrong impression. The next thing is that, what is our aim? Whether I work in a government setup or whether I work in a private setup, the role is the same. The goal is the same. We want the children to be healthy. So the roads may be the same. The roads may be different. The way we reach out may be different, but the ultimate target is the same. We want children to be healthy. We want children to get what they need, and they need to survive as independents who are going to come as a good adults for this country. So target ஒன்று தான். அதுக்கு போகிற வழி வேணா கொஞ்சம் வேறையாக இருக்கலாம், அதுக்கு போன மோட்ஸ் வேணா வேறையாக இருக்கலாம், but the goal is the same. So collaboration between these two fields is crucial for effective disease prevention and promotion of child health. We need to learn from them, and they need to also know that they are private, we are not needed. That's not the way in which we need to do, and a lot of things are happening. The private-public partnership is the thing that's going to happen now, and this is what's happening. And this is the way we join our hands and go together in a motto of do the best for the children of this country. Now, how is this possible? I'm sitting in my clinic, or I'm sitting in my hospital. I work in one of the biggest medical colleges in Coimbatore, PSG Institute of Medical Sciences and Research. So how is this going to happen? And people who are listening also, there are few people listening, and I can see in my own postgraduates. So whatever is it, the way, how are we going to interlink this two sections of the same group? The intersection can be a shared goal. I already said, our goal is the same. We want to deliver the best to the child. In whatever ways we are doing, we want the child to be benefited. So it's a shared goal. It's a common goal. There's no question about that at all. The next thing is that we have a complementary approach. I'm not alone. You're not alone. All of us are the same. So we complement one another. So a pediatrician is looking at a high-risk population. Now, he or she should collaborate with the government setup or with the other people in the society, the social professionals, to know how effectively things can be done in a good way for the child. Then, of course, we have a collaborative effect. I will touch upon each of these subheadings as I go in my talk. So we can collaborate when it involves vaccination, childhood development, chronic illnesses, etc. We will have a talk little after a few minutes. Then, of course, the next thing is the addressing the social determinants. What determines the need for a child to come to a private hospital or to a public facility basically depends upon the availability of resources. Now, if you take data now, almost 30% to 50% of children they go to a private setup for care. Now, when I say private setup, it can be clinic. There are so many pediatric clinics, and there are pediatricians there. So we have a clinic-based group who go to their clinic to get their care. There are people who are coming to private institutions to get their care. And across the country, depending upon which part of the state or which part of the country we are taking this data, it can be 30 to 50% of them can be reaching out to any of these services. So when we look at it, we are looking at why are they when they come here, what is the background? How can we help them? Are there resources which are there for this child? We need to think of a lot of things when we look at the social flag of this child who is reaching out to us. And finally, sir has already told about COVID. COVID was an eye-opener. Okay, that was a wonderful time where a lot of things happened, where public and private put their hands together to effectively seal that disease. Okay, I will come to it later on. Okay, so that these are the intersections where we can hold hands and deliver what we can do in the best possible way. Primary care and public health partnerships, pediatricians have always been there. Okay, so when I say we have always been there, even without us knowing, we are doing it. If you sit in a clinic, what are you doing? You are counseling a child, you are counseling a family, you are giving them whatever help they need, you are giving vaccine by prevention, you are giving them a nutritional advice, you are telling them if there is an emergency, you come here, you go. So you're guiding. Even without us realizing, we are actively a part of the social fabric. We are actively there to help out this family, to help out the society with whatever ways we can do. How else can we do? Other than this kind of services, the most important thing is disease surveillance and reporting. Now, we cannot say I'm in a clinic, so I don't have to report. See, last 6 months or a year back, we had outbreaks of measles. Okay, we had a large group of children coming and getting with measles, and that time we need to utilize our disease surveillance and reporting protocols. Okay, so when we have this, there are multiple, we all know what are the reportable diseases, and these are online surveillance where we can report we have seen this disease. Now, when we report as an individual, it is it's a must for us. We cannot say, I'm sitting somewhere, I cannot report. We have to report, and only when we report, do we get what we anticipate. Now, in response to this measles reporting, you have people from public health going to those areas, going to those pockets, immunizing the groups, giving them the need, please be aware. So that happens. Only when we do this, do we get the benefit, what is expected from the community health professional as a pediatrician. So disease monitoring, these are screenshots which are existing. It's in fact from our own EMR, PSG EMR, where any kind of communicable diseases, it is reported through our medical records departments electronically to the corporation. So these are some screenshots which are there, and this is the portal through which we report, Integrated Health Information Platform. Although I work in a private setup, it is a mandate, and I think we should be doing it from our own clinic. It's a software, we can get it down in our own setup, and we should report. I've seen this. And in reporting, what are we doing? We are doing a bigger service to the community. We are trying to get this area identified where there is an outbreak, and you burn the fire there itself instead of allowing it to become a forest fire. Okay, so the first option for us where a private public coordination is required is disease surveillance and disease monitoring and disease reporting. The same thing holds good for an AFB. When there is a thing, I report. See, two days back we had Guillain-Barré syndrome. So we have to report that because that child came with an acute flaccid paralysis. And immediately we had people from the government sector coming and taking the swabs and getting the information, and it is done. That is how we hold hands, and that is how we need to do to have an effective management of children in the long term. So those are the slides. The next is, of course, immunization program. All pediatricians, wherever we are working, we need to support universal immunization programs. Okay? And now it's come to a place where the government is giving free vaccines for you to immunize in your own clinic or in your institution. This Little Blossoms works in PSG hospitals. Till they are 1 year, we give vaccines which are in the national program free of cost. We don't charge them anything. So that is the partnership that we are anticipating from the private sector to do this. So there is a robust immunization schedule, and like what my earlier speaker said, the South is far ahead when compared to immunization compared to the North. And this is possible because of a robust immunization system which exists in the government sector itself, plus you have an add-on where we can do our role in the private-public partnerships. And the same thing, when I am immunizing, if there is something like an adverse effect following vaccination, it is my duty to report. It is my duty to report to the concerned authorities to be taken care of, wherever it is happening, whether it's in our institution or whether it is in a private clinic. I think that's the way to go. And this vaccination is something, we had seen it with COVID. COVID vaccinations happened everywhere. They didn't just happen in a government sector. That happened in private institutions. And that is the reason that we were able to put the flames as easily. And even the rest of the world were looking at us with, oh, these people are doing it wonderfully. And how did we manage? We had people standing in queues in PSG. It was not a private institution. It was a place that was giving vaccine. And that vaccine was free of cost. And nothing was charged. And that's the wonderful example of partnerships which can occur if it is genuinely done with service in our mind. Okay? The next thing, what we look at, public health programs. So I had a list of public health programs. All that can be put in our own private institutions. Okay, we can do with it. So we can look at the RBS case. We can have screening for developmental, the 4Ds, the deficiencies, the defects, the diseases, and the developmental problems can be done in a private hospital as well. And of course, we can refer to a district early intervention centers if it is not possible for us to handle in our own institutions or our own clinics. The next major thing is the non-communicable diseases. We have outbreaks. We are becoming epidemics of obesity in children. Okay? So these are places where we run awareness camps in schools, colleges, have programs on YouTubes. We have programs on one-to-one mode with children. Okay? So these are programs which can be done in a private setup to sensitize. So there the the goal is the same, the target is the same. We want to stop this epidemic. We want to stop the time bomb, like Dev Prasad was talking about time bomb. See, these are time bombs which can explode later on. So when it comes to obesity, diabetes, controlling asthma, we need to have a program where we can help. For example, I can again quote from my own institution. We have a program called Pearl Pediatric. Pearl Pediatric is a program which children coming with obesity, anybody can refer for that. It is not just our own. Anybody can refer from outside. We do a very comprehensive workup for their child. We have a half-a-day program where they are counseled about diet, about exercise, and all the parameters, the metabolic parameters are done. There is a robust follow-up, nothing the child pays. Okay, they don't pay anything. And we are not looking at only PSG doctors should do that. Any doctor who wants from the outside to refer a child to stop this, to stop the obesity in the long run, it's a very comprehensive program, and we have one faculty who is allotted for that purpose alone. So it is a message that anybody who wants to utilize this program are welcome to institution, and it's not just PSC, it can be anywhere, any private institution which is socially committed will do this. And it doesn't stop with my institution only. The next, of course, is going to be emergency. Tsunamis, we have teams going, and then during pandemic, COVID, we had entire hospitals, many hospitals, which took up this purpose to come out of COVID, okay? So those are the areas where a public health program can be incorporated into your own hospital. And look at this list. This is from IAP Coimbatore. I actually got it from the treasurer of the IAP Coimbatore. These are days which are celebrated by the IAP. IAP is not just people from the government sector, from private pediatricians to people in institutions. All of us are commonly united for a common cause. Okay? Look at that. குழந்தைகளின் எதிர்கால மருத்துவம். அதுதான் வந்து இந்த 49th annual conference ஓட சப்தநாடி. ஸோ அதில் என்ன இருக்குது? எல்லா டேஸ் பாருங்கள். Breastfeeding week, neonatal care week, anemia prevention week, and these are all government programs. Where are we incorporating? We are putting ourselves along with the government to help children to get well. So that is just a tip of an iceberg. So many programs, and you see, if you take IAP Coimbatore's WhatsApp group, everybody will put pictures. இன்னைக்கு என் கிளினிக்கில் நான் இதை கொண்டாடினேன், என்னோட இன்ஸ்டிடியூஷனை நான் இதை கொண்டாடினேன். எதுக்காக கொண்டாடினேன்? எனக்கு பப்ளிசிட்டி வருதுங்கிறதுக்கு இல்லை. Something meaningful was done. A group was there, and they gave something to the people who came. So something was done, and awareness was created. Something was taught. So many things can happen. This is just a list of whatever activities the IAP is doing, and this is done by a group of pediatricians from all sectors of the society. It is not just one sector, it is from all sectors of the society. A primary pediatrician will also be a team for this. When there is abuse, when there is a medical legal thing, or when there is a child welfare committee, people from outside are called. People from a private group are involved. Okay, so we can be a part of this, whatever is happening also. I am from a private sector, but still, I can do something for a child who is coming for a committee workup as well. Then, of course, in a larger scale, IAP partners with the ministries. You want protocols. You want decisions for vaccination. And then, of course, this is a very big group of many people from different areas who are there to form protocols and make decisions for children of this country. And that includes everybody. Okay, so that is a bigger picture which is there for to look for a private pediatrician or a public-private partnership in a national health management at all. And finally, this is the last slide. Okay, learning does not happen only in the government setup. Learning is happening in private. Learning is happening in everywhere. People are getting trained. UGs, PGs, fellowship people are all getting trained. And who are these young people? They are the policy makers of tomorrow. They are the ones who are going to run the show in the next. So they must not get trained just to manage shock, high frequency oscillation, ventilation, nothing. They must know about ground realities. They must know what is the social fabric of this country. They must know what is our health system in the periphery. They must be able to know this is happening, this is what I'm expected to deliver. So that is a bigger picture. So when we train residents, when we have residents training program, I don't think we should be training them. Of course, we must train them about high care pediatrics and all that. But then we should also train them about the social fabric of what they are going to see. At least 50 to 60% of them may work in this kind of a setup. So they need to know, this is what I have and this is what I need to do. This is what I need to deliver for children of this country. Okay? So medical education and training of residents, UGs, PGs and other persons, it can be nurses, it can be anybody, is one place where the cooperation between two segments of the society, the private and the public, is very, very important, because you're not stopping with yourself. It's got nothing to do with me. I may go. Next year I may retire. But then my PGs are there. My PGs are going to deliver whatever is needed to the community. So they need to know what is the social management of things and how to run about the next 50, 60 years of child health in this country. So finally, when I put that thank you slide, sorry, it is not visible, I think. So that actually the thank you slide, adu varalaya? ஓகே, அது வரல. அதில் என்ன போட்டிருந்தேன்னா வந்து ஒரு குட்டி குட்டி கையெல்லாம் சேர்ந்து நிற்கிற மாதிரி தான் ஒரு பிக்சர் போட்டிருந்தேன் அந்த தேங்க்யூ ஸ்லைட். ஸோ இணைந்த கைகள், 2 கைகள் 4 ஆனால், சரிங்களா? அது யாருக்கு நல்லது? அதில் அது வந்துருச்சு. ஸோ இது யாருக்கு நல்லது? எல்லாத்துக்கும் தான் நல்லது. இட் இஸ் நாட் த ப்ரைவேட், இட் இஸ் நாட் த பப்ளிக், இட்ஸ் எவ்ரிபடி. ஸோ ஐ திங்க் though we are traveling in 2 routes, we are going to reach the same point. And in that same point, let's join hands. Let's join hands. And it's Independence Day, so you can see the child. Any underprivileged child should get the benefits of whatever the child deserves. Wherever it is born, it should get. And I would like to thank the Pedicon organizers for giving me this opportunity to talk to this in this August conference. Thank you so much.
Thank you very much, madam. It was a very, your presentation was very clear and it was awe-inspiring. It was nice. It showed us how, as private practitioners also, we have so much of social commitment, and both the public and the private, we basically work for the children's health. So thank you very much, madam.
Hello.
I request Dr. Ramachandra Mohan ma'am for the final session. Dr. C. Satish sir, Dr. P. Sivaraman sir, and Dr. N. Sajati Begum. Managing behavioral challenges in children with developmental disorders.
Good evening to one and all. I'm extremely grateful to the organizing committee of KONGU PEDICON for having us here, and I'm even more grateful to the handful of you who have stayed back, and I'm hoping that this session will be worth your time. So, challenging behaviors in developmental disorders was the topic which was given to us. And when I went and checked, there are articles and articles about it. It is not something which is uncommon. It is something that we are seeing, and we are going to see a whole lot of, considering the present generation. So, we know that all children, at least most of them, get into some kind of mischief, and they are always termed naughty. So, when do we call it a challenging behavior? So, we'll go over to our panelists. Before that, these are just a few slides of introduction. Dr. Satish is our former Chennai City branch president, a very eminent pediatrician, and Dr. Sivaraman is a development pediatrician from E-Road. I'm not dwelling much on the, Dr. Shahjati unfortunately could not stay back because she had a personal bereavement. So the questions will be taken up by our other two panelists. So sir, Dr. Satish, please tell us, what do you mean by challenging behavior? And do give us some examples.
Sure, madam. Before I go to answer, let me thank the organizing committee and scientific committee for the opportunity given to me. To do a panel with you, madam, it's an enchanting experience for me. And I'm accompanied by a senior pediatrician with special interest in developmental pediatrics. This gives me much more pleasure. Understanding what is meant by challenging behavior, give some examples is the question. The challenging behavior is defined as a behavior which is which is dangerous, socially unacceptable, and negatively affecting the child's education. So this is a definition given to the challenging behavior. Mostly when the child who cannot express, when the child who cannot verbalize, the needs are not understood by the caregiver. When the caregiver cannot understand what the child wants, there is frustration. What is emerging out of this frustration is the challenging behavior. In short, the challenging behavior is the consequence of an unmet need. The examples are the aggressive behavior. It could be verbal, where there is abusing language, or it could be direct physical, hitting, kicking, throwing, thrashing, etc. Property destruction, this is self-explanatory. Self-injurious behavior, where the child injures himself or herself. The stereotypical behavior, meaning that repetitive movements, something like flapping, or hand flapping, rocking, shoulder shrugging, spinning, and things like that. Toe walking behavior. Toe walking, where the child walks on tiptoes, with the heel not coming in contact with the ground. Transition-related challenging behavior, meaning that we know that the autistic children have rigid schedules. They adhere to one model. So any deviation from that model, there is an anxiety. Something arising out of this anxiety is the challenging behavior. Non-compliant behavior, meaning that there is no compliance to the request, he doesn't heed to the request. These are the examples of challenging behavior.
Okay, so challenging behaviors are those that can impact the child's inclusion in the society. When it disrupts his routine and makes life difficult for him, that's when we call it a challenging behavior. So Dr. Sivaram, tell us, what is the prevalence? Is it very common to see challenging behavior among developmental disorders?
At the outset, let me thank the KONGU PEDICON organizers, IAP-TNSC, and thank you, madam, to be part of the panel. So, if you just see this study, which had quoted that the prevalence of behavior problems in children with needs was around 48 to 60%. And if you take some other studies which have showed little higher percentage, and some Indian studies which had gone to around 40%. So as a pediatrician, what I would like to tell here is, even in a typical child, you can see 10% of them with behavior problems. So definitely, if you are going to manage children with needs, we have to, it's a considerable chunk of amount which is having a high prevalence. Yes. Second is, if you take a challenging behavior in a child, most of the time, that is around 50% of the time, they come with two challenging behaviors. So that is the carry-home message for the pediatrician. Considering the risk factors. So whenever we talk about risk factors in any neurodevelopmental problem, we have to consider the biopsychosocial model, because we don't take it as just a single problem. If we take this let us take for an example of a child with autism with the challenging behavior. Let us say he has a self-injurious or a repetitive movements. The biological problem may be, okay, it is the autism, or look into the some other comorbids. This is the biological part of it. As a pediatrician, we never look into the psychological process, because we know there is already a genetic predisposition is the problem, biological problem. It may be a genetic or some other reason. There is a psychological process which we have to look into. The second carry-home message is we have to look into the social context. That is the biopsychosocial model in whenever you want to deal about risk factors with autism. So can you have the next slide, madam?
So we are just going to answer this question continuously. Yeah, tell us.
So this is just the continuation of what I told. We have a lot of biological problems in this. So it may be a intellectual disability, it may be a child with autism, it may be a child with LD. So there are so many neurodevelopmental problems. But always look into the psycho and the social models. The social model, when we take it, is basically of four things. One is the social context with the child, which we address a little, but we never look into the other problems. The social problem with the mother, the social context at the school, the social context at the environment, that is the community. So this is the most important. We always look at the child as a behavior problem with the child, but try to address all the other components of the behaviors.
Yes. Okay. So basically they may be having a problem through their genetic makeup, and the environment will be adding to the stress causing these challenging behaviors.
Yes,
Are there any comorbid conditions which can cause these challenging behaviors?
Yes, madam. There are, particularly, there are two comorbid conditions which are frequently mentioned. They are epilepsy and GI disorders. GI disorders, functional GI disorders particularly, there is substantial and robust evidence that a child with ASD, in case there is a gastrointestinal functional disorder, the onset or incidence of challenging behavior is to the extent of 60 to 80%. Why is it so? It's because we know that in a child with ASD compared to neurotypical child, the gut microbiome, what do I mean by gut microbiome? We all have a gut microbiome. Our human genome is about 25,000 genes. Well, gut microbiome is a multiple of that 25,000 genes. That exerts an enormous amount of influence. There is a reduced diversity in children with ASD. The gut microbiome, there is a reduced diversity, meaning that we have a pro-inflammatory bacteria and the ones which produce or anti-inflammatory effects on the gut biology. So there is a neuraxis and there's a gut-brain interaction, and we have some neurotransmitters generated under the influence of gut microbiome, and therefore that's something that gut microbiome influences the brain to have abnormal symptoms. There is ASD children to have abnormal symptoms compared to the neurotypical children. And therefore, those children with GI disorders as a comorbid condition in autistic children, the incidence of CB, challenging behaviors, is to the extent of 60 to 80%. The common GI disorders being GERD, constipation, pica, dysmotility, and they all produce some discomfort, some pain. The child cannot verbalize that pain, and the expression of that pain is by way of challenging behavior. The other one is epilepsy. Epilepsy per se, there will be after a fit, the post-ictal stage, there may be headache, and that headache also the child cannot verbalize. There is discomfort, and AEDs also have side effects, and therefore this epilepsy, also the incidence of challenging behavior in a NDD or ASD is to the extent of about 30%.
Yes. So epilepsy is associated with autism in 30% of the patients, and much higher numbers we see in GI problems. Okay. So does the severity of ASD or intellectual disability correlate with the challenging behavior?
Yeah, definitely, madam. The greater the severity, definitely the challenging behaviors are going to be more. So basically, if you take ASD or if you take intellectual disability, you should know what is the classification for the severity. Because the DSM tells that for autism, it could be level 1, 2, and 3. Level 1 is needing support. Level 2 will need substantial support, and level 3 needs very substantial support. So if you take level 2 and 3, definitely these are the children who will have more incidence and more severity of the problem. So if you take intellectual disability, we all know below 70 we are going to tell it as mild, below 20 will be profound, and 20 to 35 will be severe. So when it falls from the moderate to severe, then definitely the challenging behaviors, the intensity is going to be high. And if you take the intensity of behaviors with aggression, it is more common in moderate to severe ID and ASD, and younger age and poor adaptive functioning. Same if you tell ID, it is more of the severity is based on more of the adaptive functioning of the child. So this is the message we have to take.
Okay. So just a quick look already, Dr. Satish has told us that challenging behaviors may be many, like tantrums and self-injurious behavior, attention-seeking behavior, non-compliance, aggression, and property destruction. Why do we have to know these challenging behaviors? Because some of them can be treated with psychological therapy, whereas some will require medication. So one of the commonest problems that we see is a temper tantrum. And what is triggering a temper tantrum? We know that it is a sudden, intense episode of emotional outburst in a child. The child can cry, scream, stamp, throw things, lying on the floor. Sometimes it can be a way of embarrassment also, especially if the child is taken to a store. So that's a child's way of expressing his overwhelming emotions. So temper tantrums in a child, in a younger, it varies. The younger the child it is, when the child cannot express verbally, he can just be whining or fussing, or he can be clinging. An older child can just be standing like this with his hands crossed and pouting. And other older child can just be not showing interest and or have conflicts with his classmates, or not do his homework. Older children may cause social embarrassment, and they can also feel very misunderstood. So these are different ways in which it can be done. So the calming techniques are also there, and there is something called a coercive cycle. So we know that once when the child makes a demand, he says he wants something, the parents, normally what happens is how we promote a temper tantrum is to immediately give in to a child's demands. Instead of doing that, we have to try to take the child away from the situation. There is no punishment, has no role in any of these challenging behaviors. So if the child does not keep repeating that behavior, we can either do a positive reinforcement, or we can try to ignore. That probably will work best. But if you find that the child is doing well, so give him some kind of a reward at the end of it. So that is a coercive cycle. So that starts when the child is calm, there's a trigger, he gets agitated, it gets accelerated, reaches a peak, then it comes down. So that's the common pattern that we see in temper tantrums. Now, is there any way is it only clinical, or do we have any assessment tools by which we can diagnose a challenging behavior?
Yes, madam. There are two types of assessment tools, the direct and indirect. What do I mean by direct? It is directly observing the child in a setting, wherever it occurs, let it be at home, school, clinic setting. So where the health caregiver directly observes the frequency, intensity of the behavior and records it, and also scores like a scale about which Dr. Shivaram will elaborate. This indirect means you are eliciting information from the others, maybe parent, teacher, or a therapist, and try to get understand the topography, frequency, duration, and intensity. That's an indirect assessment.
So which is better, you think? Is it direct or indirect, and what are the strengths and limitations of each?
So going to the indirect method of assessment, so we have the FAST. This is the functional assessment screening tool. This is a very simple tool which a pediatrician can use in his office practice. I do use it in my practice, like using our MChat. When you have a child with a behavior, it is easy for you to implement in your office practice also. The FAST is an indirect, it's an indirect tool. So can I have the next slide? So So what is this FAST is? It is got basically into 3 domains. One will just ask you the initial questions about the type of the behavior, what is the behavior. And then it is basically 16 questions. Like in MChat you have 20, there's only 16 questions, which will ask on 4 parts. That is, we are going to talk about what is the, whether the child is seeking a behavior, avoiding a behavior, or wants a tangible attention. And there is no tangible in the FAST. It is only that the best thing about this is, as sir had addressed before, we are going to talk about pain. Because pain is a problem which none of us address in our practice to children with needs. We have a cerebral palsy with pain, we never address it. So you can definitely start using it. So what is the strengths is, it is very quick. Anyone can use it. A caregiver can do it. It's a direct observation what the caregiver is seeing. But the biggest fallacy in this is, like using all the parent-mediated scales, I always tell in my practice, just take it with a pinch of salt. Because most of the time, parents will rate it a little higher. If you see even in MChat, when the parent has done it, it will be higher. When you do it, because you're observing and doing it. So this is the biggest fallacy. There are some limitations to it.
Yeah, you can continue. Tell us about the others.
You're going to, the next thing will be the direct observation. Here, this is the, we are going to directly observe the behavior. So first, before you observe the behavior, first you have to define the behavior. Then you're going to observe the behavior. So we call this as the A, B, C, D, E. So for that, you're going to have an antecedent. You're going to have the behavior. The C is going to be the cause. The D is going to be, you're going to see what is the data. You're going to collect all the data. And then last, you're going to evaluate. So what you can do in our practice, we call this as a functional assessment. So before that, you should know what is the function of the behavior. So for the function of the behavior, this is called as the functional assessment. So when you tell a function of the behavior, there are four aspects of it. One is, I want it. That is, I remember it with the mnemonic as seat. That is, I seek for it. Second is, I escape from the behavior. 3 is, I avoid the behavior. And 4 is tangible. So these are the 4 reasons any child will have a behavior. So whenever you see the behavior, this is the functional assessment. You want to first find the function of the behavior. Then you observe the behavior. When you observe, then we are going to see the latency, first the duration of the behavior, the intensity of the behavior, how long it is going on, what is the latency, and how is the child, what are the sequences which are going to happen after it. This is called the C of the behavior. So whenever we are going to go through the case scenarios after this, we have to have an ABC and D and D.
Yeah, so these are the things. So child's behavior, go away, leave me alone. I hate doing this, means they want to avoid it. Help me when they need something, they want to communicate their needs. If they feel good, it's a self-stimulation. And when they want to seek attention, they say, notice me. So these are the 4 reasons for which a child will have a challenging behavior. So quickly we'll go through a few case scenarios and see how it is tackled. So first, Dr. Satish, Rani becomes agitated whenever her mother goes out, which leads to temper tantrums. How can her mother manage the situation?
Madam, mother knows that